we call the opportunity to combine hyperthermia with immunotherapy, because we can enhance in all the phases of the immunostimulation. We can produce what we call the vacunal effect, to produce or to turn the tumors to be more sensitive to immunotherapy in all the phases of the immunity evolution. So, to conclude, if we do the same exercise of review, the trials that are now registered in clinicaltrials.gov, May 2023, almost 2,000 trials are ongoing. But another opportunity that is going to be presented by Daniel Ortega in the next talk is to combine the nanoparticles with hyperthermia. It's a very, very promising way of developing the activity of hyperthermia. There are publications, but I think that he is going to present after in his talk, and we are trying to implement in our center in Malaga an experience using nanoparticles with hyperthermia with a company that is called MacForce. We have participated in a network called HyperNano with Daniel, SEOR, and we have periodical meetings, and SEOR has a meeting in Las Palmas the end of June to try to put together all the actors that participate in hyperthermia, not only clinicians, but researchers, biologists, physicists, to try to do the things together. To give some home messages, I have to say that Hyperthermic Oncology currently offers better clinical results because we have technological advances that we didn't have in the past. There is a growing number of countries, including Spain, with availability of hyperthermia units in oncology that offer techniques promising in combining in situations where and when we as oncology can't offer our patients good results with the treatment. Let's say brain tumors, sarcomas, head and neck tumor, liver lesions, pancreas. The combination of hyperthermia and nanoparticles is feasible and very, very promising. So we need a legal regulation. We need urgently a legal regulation to allow this technique could be incorporated to the portfolio of the National Health Service of each country. And we are working for that. And we are very optimistic, but we have to do the final, because this is presented in the National Health Service, and we are waiting for a response. So I think now it's time for hyperthermia. Thank you very much.
Thank you very much. Thank you very much, Jorge. So if you don't mind, we will take the questions in the round table just to save time. And we will proceed now with Daniel Ortega and his talk on the magnetic hyperthermia. Thank you very much.
Espérate. Mira, yo sujeto esto. Muy bien. There. Yeah. Good morning. Many thanks for the invitation. I'm very happy to be here with all of you. So I'll be talking about the basics. If it's too basic, I'm sorry. If it's not too basic, I'm sorry as well. So hopefully you enjoyed the talk. When talking about magnetic hyperthermia, what we expect or what we aim is to inject some biocompatible nanoparticles inside cells or the interstices in tumors, apply some alternating magnetic field, and induce some damaging affecting tumors, or at least sensitize the tumor to become more receptive to radiotherapy or chemotherapy. This is what we expect. So I want to give you a little bit of history, if I can call it like this. And I put together this brief timeline about magnetic hyperthermia, not the hyperthermia as such, but just this therapeutical modality. So the first seminal experiment done by Gilchrist in 1957 in dogs having, I think it's sort of a lymphoma. So he placed some small bits of magnetic materials and he applied some AC fields, and he saw that the dogs were, showing some kind of degree of improvement. Then there was silence during the 60s and almost during the 70s. And so we saw that during the 80s, I don't think that the pointer is working on us here. During the 80s, we saw some activities in trying to find out the tolerance to magnetic hyperthermia. And then we saw, for example, in important work done by Vresovic about the, try to put a limit to the heat level that we can apply to a patient in a body region. Then during the 90s, it was the time for setting up, I would say, some seminal preclinical studies. For example, so probably most of you know the Andreas Jordan team or group. So they worked a lot on trying to put together ways to quantify the heat coming out from nanoparticles that we could use for magnetic hyperthermia. So it was like a bit of the starting of this new magnetic hyperthermia thing. Also, physical ways or models, if we want, to try to predict how much heat could be extracted or from magnetic nanoparticles. Then during the 2000s, we got the outcomes from the first clinical trials. I would say 100% done in Germany, in several indications, prostate, glioblastoma, and also I think what else? Something else that I'm missing now here. Then we have the MacForce company in 2010 that became the first company having the CE branding for their equipment. And then during the 2010 onwards, we have more and more studies trying to get to the bottom of the body response to magnetic hyperthermia, perhaps trying to get closer and closer to nanoscale effects. And then more recently, we see how we can combine other diagnostic techniques with hyperthermia to put together a theranostic technique, which I think that is the future of all this. I want you to reflect on something. Where does the magnetism coming from? Some of you will know, some of you will not. It's all about electrons. Electrons has a magnetic moment associated, and these magnetic moments are not static. So they are moving following, this is called the precession of the electrons, okay? So they are moving at a certain frequency. So they couple to an external field. When we apply the AC field, we are coupling this precession movement with the field. And this is more or less, this is where the heat is coming from. So I'll give you more details now. So we have the theoretical body knowledge of what's happening. So I'm putting these equations, do not pay much attention on the equations themselves. So I want to draw your attention on the different components here in this equation at the bottom. The particles injected in the body will fill not only the external field, but other contributions as well. So we have other contributions like coming from the anisotropy, thermal fluctuations, as well as the interactions between dipole interactions between nanoparticles as well. So they see a different field, okay? It's not just the external field. Well, we have here, probably you know Niels Bohr, what was the name of the other guy? Oh, yes, thank you. So they are watching this procession moment, spin top, okay? So they were having such a great time doing physics. Good old days. Yes, so if we can have a look at a set of magnetic nanoparticles, these are iron oxide magnetic nanoparticles, how can we know whether or not we are getting heat from them? Well, studying the interaction with external fields and recording all the heat processes.
Claro, es que yo se lo había dicho a Sergio, pero creo que se ha perdido la información por algún sitio.
Here. That means that it's not depending on time. We see a curve that is looking, there is no area.
Claro, claro, pues es que era la misma que al final ha podido
energy exchange here from the
entonces le dije a esto y me dijo, no, entonces que en vez de venir en julio que aparece claro, el anexo 3 que yo os mandé en realidad no se ve
an AC field which is time dependent.
Aparece y que es válida.
We see that this curve,
y pone que es válida, pero tienes que dar
we see that there is some area, some magnetic energy,
y por eso yo no podía como separar
it could be seen microscopically as heat coming out from the nanoparticles, okay? So this is opening of this loop is coming from the lag of the magnetic moments. Do you remember that they were precessioning? So they want to follow the external field, but there is some lag, right? So this lag is causing this opening of the hysteresis loop, okay? Right. Can we, put together some numbers on this and calculate, the precise amount of heat that will come from a set of nanoparticles? The answer is yes. So there are many ways. Chi double prime, which is the imaginary or out of phase component of the magnetic susceptibility. And I want you to pay attention to something that it's happening inside the, well, not inside the nanoparticles, but in nanoparticles when you're applying an external field. We have two different mechanisms for the particles to relax. So we have a mechanical one that it's called the Brownian or Brown relaxation mechanisms, by virtue of which the nanoparticles are rotating physically, nanoparticles and the magnetic moments inside, everything. And it's due to the friction with the molecules of the solvent where the nanoparticles are suspended. So it's a mechanical relaxation, right? And then we have what is called the Neal relaxation mechanisms, which is just a magnetic relaxation. We have the rotation of just the magnetic moment, okay? So we can get heat either way. The thing is, what may happen where you put the nanoparticles and whether or not you might be preventing one of these two mechanisms to happen, and then you lose your capacity of getting heat out. In vitro, so you know that there has been published many in vitro studies on how the magnetic hyperthermia can proceed in cell culture. I'll give you an example here of the many that they are available in scientific literature. So we know how the magnetic nanoparticles get internalized into cells in this perinuclear arrangement of endosomes. So they may become full. These are DX3 melanoma cells, by the way. So once we have the nanoparticles inside, we can apply a magnetic field. And here on the bottom row of images, you can see some, if you do not go too far with the heating, and you apply like a sort of a mild and gentle heat load, you can just convince the cancer cells to become apoptotic. So, and we can actually see like the cells are starting to losing ultrastructure. So we can see, for example, some bleeding, which is another symptom, so to say, of the apoptosis, or even the cells will lose the membrane and will release the cell contents out. So it's working, and we have ways of tracing or following or tracking this hyperthermia happening in situ or real time, if you want. Here, there's a short video. You will see green and red patches in this video you want to see. So these are just two different kinds of fluorophores indicating either early apoptosis or necrosis happening. So for example, don't tell me that it's not working. Can you just play the video for me? Just click on it. Said no. So, yeah, well, don't worry. Well, it's available. You can actually, I think there's a, if you take the reference, you can have a copy of it, I think. If not, just tell me, so I can pass you on. Sorry about this. Well, in any case, the important message is that we can see how it is proceeding and how it is this magnetic hyperthermia happening in cell culture. All right. Not working. Sorry, gentlemen, it's not working. No. No, not working. Yeah, thank you very much. Have we got any other means to try to track the process of magnetic hyperthermia? Yes. If you remember, I was talking about before two different heating mechanisms. Yeah, do you remember the mechanical one, or Brownian relaxation, and the Neal relaxation? It happens that we have AC susceptometry, which is a measurement through which we can track these two relaxation mechanisms, which are responsible of the nanoparticle heating. And we can track what is happening. For example, when we are injecting, we are putting nanoparticles in a cell culture, or we are trying to inject nanoparticles in a tumor. And now you see why I'm telling this. So the important thing here is that at the left graph, you can see that at different frequency ranges, you will see a peak or a band that is happening, and it's giving you information of the nature of the heating mechanism that is happening, okay? So it's easier. So in water, you will see both mechanisms happening. But when you are placing the nanoparticles in a very viscous media, what is happening? At the end of the day, you're restricting the movement of the nanoparticles around, so they cannot mechanically rotate. So you're killing one of these two heating mechanisms, right? So this is important. So if we don't see any peak here, so we know that the cell is not heating, the nanoparticles are not heating through this mechanical friction, all right? So this is giving us this kind of information. And this can be translated also in the shape, I would say, and the area and this hysteresis loops as well. I'm not getting into this. Perhaps this is more interesting. So back in 2015, the Sokup and the collaborators, so they put together a quite interesting experiment, and it was, can we actually track what is happening to the nanoparticles when placed in different medium, like cell culture or a tumor inside a tumor? What is happening to the heating mechanisms? Well, what is happening? So when they are in water, we see that there is a, well, here we cannot see the Neal relaxation, but it's happening somewhere here as well, the peak. So it's happening what is theoretically expected. Yeah, so they're free to move. Now, when you are getting the nanoparticles in glycerol, for example, which is quite viscous, you see that there is no Brownian relaxation peak here that should happen at some point here, right? But now when you are getting the nanoparticles into cells, which is not so viscous, is more than water, but less than glycerol, you see that what happens is that the Brownian relaxation is taking place, but there is an effective shift. All right, so now, by virtue of this curve, we can see what kind of restriction is taking place on the nanoparticles, right? Well, what happens if we perform a lysis of these cells and then release the nanoparticles? Can we restore the magnetic properties of the nanoparticles again? Is this process reversible? The answer is yes. What they did is just the same kind of experiment, but after cell lysis. And you see that after performing a lysis, you can restore these magnetic relaxation mechanisms. So the nanoparticles were getting trapped inside cells or tissues. They do not heat out sometimes if the main heating mechanism is the mechanical one, right? But when you release the particles away by cell lysis, you restore back all these Brownian relaxation and near relaxation mechanisms. So they can heat up again. So they can be reused if you want, okay? And this all just with this magnetic technique. In vivo, yeah, there's a lot of evidence, and you know this very well. So I'm just featuring this study by this is the group of Ingrid Hilger. I think this one is kind of cool because they were using micro-CT to locate where the nanoparticles are distributed inside tumors after injection, and I think it's quite visual in telling you, where the heating is being concentrated and also the disease progression and how the tumors are shrinking over time. Of course, so in these studies, they did, just the injecting the nanoparticles, just the heat, nanoparticles plus field, etc., etc. So more evidence there was, yeah, but I'm not getting much into this. Something, this is like sort of a word of caution, is that the current paradigm is that we expect the nanoparticles to, when we inject it in the tumor, the nanoparticle to go through the spaces or the gaps in between endothelial cells. And there's a very recent evidence, I don't know what was the year, but probably like 1 or 2 years ago, they published like a quite thorough study here in Nature Materials, telling us just the opposite. Okay, so it happens that the nanoparticles are entering the tumors using an active process through endothelial cells, not just in between the gaps, okay? So they are responsible for up to 97% of the nanoparticle internalization process within tumors. Quite interesting. Now, not everything about magnetic hyperthermia is complete, understood, or it's free from issues. So we have a lot of issues. For example, one of them is this. This graph is just a huge graph encompassing a lot of different reported studies, either in vitro, in vivo, or even clinical trials, etc. And what I want to stress here is all these points that you see on these big spheres are telling you the spread of the different conditions, field conditions applied in treatments. So what I want to say with this is that there is no consensus of what conditions, what kind of indications. Shall we go even further, or we have to go back and rethink? I don't know. So, and this is just made in 2015. So probably if we try to complete this graph, the thing is even more spread all over. So we have to think about this. Other thing that probably you recognize this picture. So this is a courtesy of Dr. Angel Millán here present. Another big issue is thermometry. So we are having in magnetic hyperthermia things happening at the nanoscale, and also things that we can see and measure macroscopically. So nanoparticles are producing heat, but the heat is being expelled and it's decreasing the temperature at the surface of nanoparticles like very quickly, all right? So we need a lot of nanoparticles being activated to have like a microscopic temperature raise. And not always we have such a thing. So we may have a therapeutical effect and we are not able to measure a noticeable temperature increase. But there are ways that we can trace this nanoscale temperature. For example, by using fluorescent probes that could be attached to nanoparticles, or even luminescent nanoparticles that are emitting at certain temperatures. So for example, we can, so I don't know, Angel, what kind of fluorophores were you using here? Or they were like luminescent nanoparticles?
Therium and
Therium.
complexes.
Okay, right. So you can see here, so these are these nanoparticles are internalized inside cells. And actually, you can have like a temperature map of it, right? It could be more or less indirect or direct way to measure temperature, but this is a way. Of course, if we are introducing new nanostructures or particles or chemicals, it will be even more difficult to get approved and get studied. And yeah, but this is something that we should look into. Okay, so these are a direct way of measuring temperature at a nanoscale. More issues in magnetic hyperthermia nowadays is people bearing either passive or active implants, metallic implants, because we know since the times of Faraday that any metal will heat up upon exposure to an AC field. They get that way. Actually, we are taking advantage of this electromagnetic induction heating, for example, in jewelry. So when you want to melt any metal, you just apply it in a radio frequency field within the kilohertz, and then the metal will melt down, right? So we can heat up processes if we are applying a kilohertz AC field to patients. So that's why this is an exclusion criterion in magnetic hyperthermia treatments. So here, this is a study theoretical study that we did, trying to find ways of, could this be somehow fixed or at least alleviated? Are there any ways, or how can we predict how good or bad could be this heating? Well, the answer, there's no unique answer, and it depends on the type of processes. It depends on how big it is. It depends on the location. It depends on how far the field that you're applying. It depends on the alloy that the process is made of. It's very complex, but I think it's something that could be theoretically predicted. And I think that this exclusion criteria could be reverted. So there are solutions to this. We also did studies on more complex structures like these filamentous biliary stents. So they heat up. Yes, they heat up. But depending on the orientation and the field conditions that you are applying during the treatments, you may alleviate this heating. All right, so here in this simulation over time, you can see that as the time is passing by, so there's heating being developed at some point, depending on the orientation of the field that you are applying. And you can have as much heat, as a 12-degree increase and even more in these structures. But there are ways to tackle this. I just want to show this up. And probably Professor Pankhurst could tell us more about this. So there are another ways to alleviate this could be to use a pulse field applications instead of a continuous application, for example. And this is something that is under study, right? I'm not getting much into the clinical thing of this. And what about the future? I think that we need the help of a diagnostic technique that could be put together to monitor how the magnetic hyperthermia treatment is progressing in real time. So I'm giving you an example with that is using a similar field it's also an AC field and is using the same kind of nanostructures, iron oxide nanoparticles, and it's magnetic particle imaging. This was a technique that was devised not too long ago, and actually the engineers from Philips, they kind of invented the technique, received a prize for it like not too long ago, back in 2017 or something like this. So the good thing about this technique is that you can track where the nanoparticles are traveling in the body. So if you attach any molecular probe to the particles, you can actually track where this thing is going inside the body. So if you are doing any drug targeting, you can track it using MPI. So far, we have preclinical scanners available, but there are also preclinical modules that combines the imaging of the MPI and also a setup for applying magnetic hyperthermia at the same time. So here's you have the sliding chamber for mice. So you can at the same time track where the nanoparticles are, what's the heating at the place of the nanoparticles, and also to monitor how the hyperthermia is progressing. So this is what we call a theranostic approach of the thing. So in my opinion, this is the future. And the only two manufacturers worldwide, which are Bruker and Magnetic Insight, are kind of trying to, they are competitors at the end of the day. So they want to get the first to the market, you know, in combining this and made clinical systems available to the people. So they recently got quite a chunk of money to further develop this into the clinical. So, yeah. So I want to finish off with this now. So there are many other issues, and even more than the ones that I'm putting here for you. So still, we need to come into a consensus for reliable metrics, and that's suitable for magnetic hyperthermia, not just for hyperthermia, but precisely for magnetic hyperthermia. So what kind of SAR? There are so many, and we can normalize the SAR to whatever we want. Is CEM43 still valid? Are there any other alternative metrics for it? We are also struggling with an accurate localization of the nanoparticles inside tumors as well. So there are no simple ways of doing this, at least using medical imaging. And also there are another kind of administrative burdens that are preventing us to even further move forward with the magnetic hyperthermia. But perhaps this is something for the roundtable discussion, all right? Yeah, I had the pleasure to coordinate this HyperNano network in Spain. So what I tried to do is to combine all the very nice research group doing something different in different sites of the magnetic hyperthermia in Spain. And there's such a broad range of expertises here together that I think is worth, you know, just even try to join more and engage more people and take this forward, because there's no other way to move forward in the field that bringing all the available knowledge and try to, you know, think about ways of improving this. Yeah, and also, of course, put together projects and get the money, because without money, we got the brains, we got the people, but we need more money. Well, thank you very much for your attention. Thanks.
Can you hear me? Yes. So thank you, Daniel, for your nice basic, but also not that basic about the magnetic hyperthermia. It was very nice to see everything together. So now we have on stage Teresa Macarulla. Again, we will take the questions, if you don't mind, at the round table session. For those of you that are attending online, you can leave the questions on the chat of the Zoom, and we will take them back on the round table. And now we will proceed with Teresa Macarulla. Teresa, whenever you're ready, we can start your talk. Would you prefer to have the... Yeah. Okay, thank you so much. So thank you for the invitation to be here to share. Basically, I will present and share the data of the patients treated in our institution in the NanoCancer project with you. It's only few patients, but I think it's interesting. It's first step, and then we can discuss what, how to move forward, etc. So first of all, our patients and our project, the NanoCancer project, are focused in pancreatic cancer, and why we decide to apply these nanoparticles and hypertermia in pancreatic cancer. First of all, because pancreatic cancer is one of the tumors with less improvements in overall survival in the last decade. And as you can see here in this slide, the number of new diagnoses are more or less the same. So a lot of work to do. That's the reason why we focus in this. Reason, but this is one of the reasons. For this, it is expected that pancreatic cancer is the cause of mortality in 2030, 2040. So really, a lot of work to do, and it's really unmet. What happened with pancreatic cancer? Normally is diagnosed. And another important point is a tumor that is not so chemotherapy. Why? Because we have this stroma that is surrounding the tumor cells, and that it's a physical barrier for the chemotherapy arrive to the tumor cells. And for this reason, the majority of strategies with chemotherapy that we tried in the past, a lot of clinical trials, we have a lot of negative clinical trials, and in fact, we have two treatment options in first line, that is chemotherapy like gemcitabine and nab-paclitaxel, or FOLFIRINOX. And this is the only two treatment options that we have for our patients. And here we have the problem. We have the tumor cells in the middle of the tumor, and around these tumor cells, we have all these dense stroma that it's a physical barrier. Also, it's dynamic, the stroma, because we have some cells in the stroma and cytokines that stimulates the tumor growth. So it's something that is dynamic. Well, so we have some experience in pancreatic cancer with nanoparticles. For example, nab-paclitaxel, it is our standard treatment in patients, in which we put in a nanoparticle the paclitaxel, and with this we have a positive clinical trial. When we treat in clinical trials pancreatic cancer with paclitaxel itself, without this nanoparticle, the trials were completely negative. So we have the example that using this strategy, we improve the efficacy of this drug. And with this, we can, when you give a patient these nanoparticles, we know with paclitaxel inside, we know that we can affect the stromal of the tumor a little bit, and we can arrive to the tumor cells. And that's more or less the same. So we focus our project in locally advanced pancreatic cancer. So what does it mean? It's a patient with a tumor in the pancreas without metastasis, but not candidate for surgery. Normally because the tumor is affecting or is infiltrating the vessels around the tumor. And this means more or less 20–30% of all the patients with pancreatic cancer. Unfortunately, you can see here the overall survival at 5 years, it's 0%. So majority of patients presented a median overall survival around 1 year, more or less around 1 year. So then, as you know, in the NanoCancer project, it was this Horizon 2020 project in which we started to testing if we can apply nanoparticles, and then after these nanoparticles, in this first part of the project, we have the nanoparticle research, how we can produce these nanoparticles, etc. And then also the how to implement the hyperthermia, the machine, whatever. Then we have the preclinical work, all this part with the preclinical validation. And finally, we were in charge of this clinical part. This was a trial that it was a feasibility trial, nothing else. And that's what we have to have in mind. So only feasibility trial. So it is possible in a pancreatic cancer patients with locally advanced disease to apply the nanoparticles and then to treat the patients with hyperthermia and chemotherapy. So that was the question So the inclusion criteria, it's patients with locally advanced pancreatic cancer, not candidates for surgery, acceptable, of course, renal and liver function, because those patients have to be treated with chemotherapy. And then we have to have the confirmation that our patient presented an adenocarcinoma of the pancreas. 95% of the tumors in the pancreas are adenocarcinomas. And then we have other kinds of tumors with different prognosis. So we try to put an homogeneous population. And then initially, the exclusion criteria, or one of the main exclusion criteria, were the metallic biliary stents. Unfortunately, it's really common to have biliary metallic. So unfortunately, majority of our patients with locally advanced pancreatic cancer, 60% of them, 70% presented the tumor in the head of the pancreas, so close to the bile duct. And for this reason, a lot of these patients needs biliary stent to drain the bile. And for this reason, majority of them, a lot of those patients presented needs a biliary stent. So it was a limitation for the inclusion of the patient at that point. Then a lot, trying.
Yeah, so these two everything inputs are, we do not have any information as of now if they are actually rolling off or any extension being discussed around this. So that's the reason only two are there, but probably by to the end of the day we'll get the clarity. And
but then Rahul, like, you know, again,
we can put particles.
would you know, like Sara and Sebastian, they are from which area, and so that we can directly follow, because today
if we want to arrive to the pancreas, for example, for the biopsy or for even the nanoparticles, we have to go through the stomach and then have to punch through the stomach the pancreas that is here behind the stomach. So this is an endoscopic ultrasound. When you arrive to the stomach, you are applying an ultrasound. You can see where is the pancreas that is here, and then you punch the pancreas. Ideally, the head of the pancreas that is here, because if not, sometimes it's far from the stomach. And then through this, we inject the nanoparticles to the pancreas, to the tumor of the pancreas, in the middle of the tumor. So, and this is the machine that applies the hyperthermia to the patient. As you can see, this is the machine, and then the technical issues is pointing to answer the questions after. But then you put the patient here. Normally, the belly of the patient is here, and here is the we apply the hyperthermia from here to the patient. No? Normally, we try to apply the hyperthermia to the abdominal part where it's supposed to be the pancreas. So the primary objective and main objective of this project, it was safety and feasibility, mainly feasibility. We can do it or not. And then, of course, we have other secondary objectives that today we cannot answer because we have only few patients. So this is the design of the trial. So first of all, we identify the patient in our institution in Vallebron. Once we identify the patient, we have a multidisciplinary tumor board in which every Monday we discuss all the patients, and with the radiologists, we define if a patient presented or not a locally advanced disease, so not suitable for surgery. And then if the patient presented these characteristics, we explain to the patient what is the project, sign the consent form, and then we have, first of all, an MRI. Why? Because we have as an exploratory objective a radiomic project in which we try to see if we can define the tumor, whatever, with the radiomics. And then we have some exploratory, more exploratory plasma biomarkers, ctDNA, and also CTCs. And then we start with the nanoparticles injection. We go for the endoscopic ultrasound. We apply, our endoscopists apply the nanoparticles, and then we have to do a CT scan without contrast in order to be sure that the nanoparticles are in place. You will see now the results. After that, if the CT scan is fine, then and the nanoparticles distribution is within the tumor, we start with, first of all, with the hyperthermia, and then, first of all, hyperthermia, and in 10 minutes, we start the chemotherapy, gemcitabine and nab-paclitaxel. And then gem and nab-paclitaxel is a chemotherapy that we have to apply every week, 3 weeks on, 1 week off. So that's what we are doing here. Hyperthermia, chemotherapy. Next week, hyperthermia, chemotherapy. Next week, hyperthermia, chemotherapy.
and that's all. We finish here the project. So the patients are treated with hyperthermia and chemotherapy only during the first cycle, the first month. And then we repeat the CT scan in order to see the situation of the tumor, and then the patient continued with the standard treatment. So whatever we want to do with the patient. So clinical cases, I will briefly discuss with you these 4 clinical cases. The first patient, it was a 47-year-old woman from Canary Islands. So this patient fly every time from the Canary Islands to Vallebron in order to receive the treatment because he wants to be included in a research project. This patient started with epigastric pain in January 2022, and then in the Canary Islands they perform a CT scan and they see this tumor in the pancreas that in theory it was affecting the arteries that around the tumor, so it was unresectable. The CA99, that is a tumor marker that we use in pancreatic cancer, it was elevated 1,900, and then they took a biopsy through this endoscopic ultrasound and it was compatible with adenocarcinoma, so she came to our institution to be treated with a second opinion to be treated in a clinical project. So we discussed the CT scan in the multidisciplinary tumor board and it was unresectable disease, so we can think in this strategy, no cancer project. This is a CT scan of the patient, and here this is the pancreas, this is the pancreas, this is the stomach in front of the pancreas, and here is the tumor. You can see here is the tumor. So it's a tumor that the size is this, like 30 per 35 millimeters. So this is the day that we treat the patient, the first patient, and here it was the endoscopic place where we inject the nanoparticles, and here you can see the needle with the nanoparticles, and then they go through the stomach and punch this to the pancreas. As you can see here, there was no problems, no complication injecting nanoparticles, and that's important because we have to punch through the stomach. No complication, but you have to see that here is the CT scan, the tumor, and it's very difficult to see the nanoparticles. So that's something that we can discuss, and we discuss a lot with our radiologists. In theory, because these nanoparticles presented iron, we have to see the CT scan, but maybe here, I don't know, you can see something here, but we don't know, we expected more. So that's the situation, and it seems there's nothing outside of the pancreas, but maybe yes, we don't know, it's very difficult. So it's difficult. And then we start with hyperthermia. This is the first day, 7 o'clock in the morning. We are treating our patients, so, because we need a lot of space to do it, and we don't have this space at normal hours, so we have to start really early with the patient. And here is the patient. Here is the abdomen, and in theory, here is the pancreas. So we apply the hyperthermia to the patient. And then after that, this is our patient. And then after that, the patient started with chemotherapy. And we repeat it every week. Cycle 1, day 1, hyperthermia, chemotherapy. Cycle 1, day 8. We have to, the patient explained that after the first chemotherapy, the pain improved. The patient presented those patients presented a lot of pain due to the celiac lung, and we have to perform a blood test in order to see that all is fine for the chemotherapy, and we have only this grade 3 neutrophil decrease, maybe higher than expected only for chemotherapy, but we don't know. An increase in the tumor marker and after the first injection of chemotherapy, and then we continued with the treatment, and then the last one in cycle 1, day 14. Again, tumor marker increasing, but then we can see that decrease. So after that, at the end of treatment visit was after this first cycle of treatment, and the patient presented no pain after the first month of treatment, no diarrheas, no complication. And here we can see that the tumor marker start to decrease after the first month, not the beginning, but then start to decrease the tumor marker, and the CT scan, the lesion of the tumor a little bit smaller, but more or less the same, what is expected. And then the patient continued with chemotherapy for 6 cycles. That is the standard treatment in our institution, without hyperthermia, without anything else, with a stable disease. And then the patient go for chemoradiotherapy in order to consolidate the treatment. With the tumor marker, you can see that decrease less than 1,000. And now, unfortunately, the patient is in local progression and unfortunately very sick and cannot be treated with any more treatments. The second case is a 63-year-old man from Poland. The patient started again in January 2022 with back pain. That is very typical from these patients. Here is the tumor, as you can see. Here is the big tumor that this patient presented. Again, this is a locally advanced disease with no metastasis, so can be applied in the Nocanter project. Is an adenocarcinoma again, no CA19-9, so we don't have the tumor marker. And the patient accept the project and start the treatment with no complication. We performed the CA19-9 and you can see 627. And then again, the nanoparticles were injected with no complications, so really an easy process. And then again, if you can see here any nanoparticles, it's very difficult. The tumor is here. And here it's even more difficult to find any nanoparticles. Where are the nanoparticles? We don't know. Then the patient starts with chemotherapy again, and the hyperthermia, and then chemotherapy. After the first cycle, the patient has to be hospitalized due to the worsening of the back pain. But then after the second cycle, the patient starts to improve the back pain. And finally, so we can see that really there is a clinical benefit in the patient. So we can give all the chemotherapy with hyperthermia with no complication, with improvement of the pain and a little bit decrease in the tumor marker. After the treatment, the patient presented after the first cycle improvement in the back pain, improvement in the tumor marker, CA19-9, and the CT scan more or less, a little bit smaller, the tumor in the pancreas, but more or less it's the same as expected. So again, this patient was treated with 6 cycles of treatment, no toxicities. Then he can be treated with radiotherapy. Tumor marker, it was negative at the end of all this treatment, and now the patient is in follow-up with no progression. Third case is 77-year-old man with no medical history except for hypertension, tumor in the head of in the body of the pancreas, a tumor marker increase 1,300, and then the patient is presented in tumor board. It's a locally advanced pancreatic cancer, adenocarcinoma, so can be treated in the tumor Nocanter project. Again, nanoparticles with no complications, and started in June 2022 with hyperthermia and chemotherapy. Again, I think this is after the nanoparticle injection. In this case, there is contrast. Maybe here you can see something. I don't know. It's very difficult to see, even for the radiologists. I am oncologist, so I don't know about it. But for the radiologists, they said it's really, really complicated to see it. So I don't know. And then this patient again started with the chemotherapy with no complications, only grade 1 nauseas, but nothing else. Blood test within the normal range, decreasing again in the tumor marker, a stable disease in the CT scan, and so very similar to the other ones. Patient completed 6 months of chemotherapy and then radiotherapy. And again, the patient today is in the follow-up with no progression. And the last patient is a very young man from the Canary Island, also 43-year-old man with no past medical history of cancer, hypertension, and the patient started again with back pain, epigastric pain, and a CT scan show a tumor in the head of the pancreas, locally advanced, positive for adenocarcinoma, tumor marker absolutely negative. So the patient come to our institution searching for more opportunities, and we explained our project, and he decided to be included in the trial. In this patient, again, no complication from the nanoparticle injection. Cycle 1 with no issues, but after start chemotherapy, she presented a decrease in the neutrophils count higher than expected again. So we cannot give the second cycle of chemotherapy, but we can give the third one. And then the patient presented the CT scan with a stable disease, CA19-9 negative. So we stopped the project and we completed 4 cycles of chemotherapy. And after that, it was a tumor reduction. So we decided to present it to the multidisciplinary tumor board in order to see if there's any chance for a surgery after this tumor reduction. Unfortunately, this is again, after nanoparticles injection, nothing. Maybe here, I don't know, there's something very difficult. Well, so this patient, young patient, really fit, really strong patient, can go to surgery, a very aggressive surgery. The tumor can be resected with a total, here is missing, but total pancreatectomy. This is a very, very aggressive surgery. And when you see the tumor, we have the tumor out, and we can see that when our pathologists try to identify the tumor regression, that it's something that it's important not to see what we did in the tumor. It seems that there are some regressions, but still 30% of tumor in the tumor and 30% of fibrosis. So not maybe we can expect more necrosis, more but it cannot. So we cannot see it in the tumor after the takeoff. So this patient now is without tumor. It's in follow-up, and in May 2023 we visit the patient for the last time, and it was fine, a little bit. So recovering from the surgery, but it was really important surgery, but fine. So that's all. So for me, questions for the discussion: why we cannot see the particles in the CT scan? If the particles contain iron, we don't know, but it's a limitation, because we cannot see if we have the particles in the adequate place. The dose of the nanoparticles, we don't know. We have different sizes of tumors. We don't know if we can inject more dose or not. Maybe we can increase the dose. So we would like to see more necrosis in this tissue, when we have this tumor out, and we don't have a lot of necrosis in the tissue. Biomarkers, still a lot of things to do. We are now starting to evaluate the ctDNA, the CTCs, and also the radiomics, but we don't have the results yet. And finally, we can treat those patients with the other treatment option that we have for FOLFIRINOX, that is different chemotherapy agents, and maybe we have more synergistic effect, we don't know. Next step, of course, is to publish the data that we have today with all the exploratory biomarkers. Also recruit, thanks to the SAFE project, now we can continue recruiting patients. We'll try to have a larger cohort of patients, maybe 10 patients with locally advanced disease, and try to include patients with biliary stent in order to be sure that it's safe. Analyze the data when we have more patients, in order to see if this is feasible, and we have some signal, because here it's very complex, because we have a lot of players. We have chemotherapy, we have hyperthermia, we have radiotherapy, so it's very difficult to see if there's some signal here, but to analyze the data in order to see if we have some signal, and we have to someday go to randomized trial. That is the only way to demonstrate that hyperthermia plus chemotherapy is better than chemotherapy alone. So that's the only way. And finally, there are exploratory biomarkers that will help us to understand what is happening in those patients. And thank you for your attention.
So thank you very much, Teresa. You did it on time perfectly. And now we will have time for 2 questions before the coffee break, if you want. If there's any question in the room.
Thank you for the presentation, Teresa. Do you think there is any synergy between chemo and hyperthermia? Do you think it's rational to do that?
I'd like to think that there's a synergistic effect. No? In theory, especially in this tumor, that we have all this stroma around the tumor cells, in theory, what we think is that these nanoparticles inside of the tumor, when we stimulate these nanoparticles with these magnetic fields, in theory, we are changing the stroma and the microenvironment of the tumor. Unfortunately, it's very difficult to demonstrate it. So we have the data in preclinical data, but in the patients.
But I mean, there's any previous experience in the animal setting or something like that? In the PDAC tumors, I mean.
We have all the previous, so all the preclinical data in this project, and we have the data from the animals, from the PDX, in pancreatic models. And in theory, yes, we are changing this, then in patients, it's very difficult. Even if we have a patient that can go to surgery and you have all the tumor and you can analyze the tumor, but you don't know what you are finding this. It's for the nanoparticles, it's for the hyperthermia, it's for the chemotherapy, for the radiotherapy. So who knows?
And the other question, how about the possible complications? Because it's not an easy procedure sometimes to punch the pancreas through the stomach, and can lead to some pancreatitis and some other complications. Very important sometimes, so very relevant.
Absolutely. In fact, there's some experience injecting not nanoparticles, but maybe other treatments in the pancreas. And sometimes there's it is described that you can have all these complications. In our experience, we have these 4 cases with no complications. It's true that I think it's crucial, the experience of the team. You need a team that are highly experienced in this. For example, our endoscopist is always doing this. It's one endoscopist that it's always doing endoscopic ultrasound to pancreas, punching the pancreas. So the experience of the team is crucial. But of course, it's something that it's aggressive. It's not easy to do. Yeah.
I suppose when you have all these particles inside the tumor, you can repeat the procedure many times if you want. There is no rationale to do that.
Yeah, we don't know. Yeah.
Okay, yeah. Thank you very much.
The only thing that one interesting thing, the only thing that we observed in the preclinical models, it was that when you put the nanoparticles, you have the hyperthermia, and the tumor increased the temperature, in the animals. But then when you did it more than 3-4 times, the temperature didn't increase. That's the reason why we did it only one cycle, because in theory, if you repeated the hyperthermia in the second cycle, there was no effect in the tumor, in the preclinical models. Ivan, I can comment more, but yeah.
In the case that you remove the tumor, on that tumor, were you seeing the nanoparticles in the tumor?
No, not specifically. So the pathologies, this is very complex. You can imagine that the tumor presented, it's a big tumor with a lot of necrosis. This is nanoparticles, so it's very difficult. She didn't find anything not special. And it was a long time. So when the patient received the nanoparticles, after 6 months, more or less, it was the surgery. So 6 months after the injection, who knows where those nanoparticles were, It was 6 months. It was not immediately after the nanoparticles injection. So I don't know, maybe they moved. I don't know.
Oh, thank you, Teresa. Nice presentation. Your study could be a pivotal one for this field, but we need at least one proof of evidence. Only one, because your image is a little bit not so evident images.
This is the feasibility study. This is only that this is feasible. That's all.
I think, in my modest opinion, is that you need to define a point after 2 or 3 treatments in which you perform a new biopsy. A new biopsy should be. Because I appreciate, but I think that we need only one, but a proof of evidence.
But what are you looking in this biopsy? What are you looking for in this biopsy?
No, because
necrosis, for example.
You use a very thin needle, not traumatic for the patient. You are a very skilled equipe, no problem for the patient. You can analyze what you want, but first of all, okay, necrosis, but also the environment, what is around that, and you can find also which type of immune cell inside, something more that you don't have in this study, but it's a brilliant one. I appreciate.
I think it's very difficult because you have also the chemotherapy working, and you don't know the effect of chemotherapy. So if you have a biopsy, first of all, that the biopsy is through the stomach, it's not so easy to have a good biopsy. You have a biopsy, but not so representative of the tumor. And then you can have some necrosis, you can have less fibrosis, but what?
The main problem that we have in oncology is more is better. This is not true.
No, for sure. So, yeah. So I mean, I think it's very difficult to demonstrate that to give hyperthermia plus chemotherapy, it's better than chemotherapy alone. It's very difficult. But with the biopsy after the treatment, I don't know if we can see anything. I don't know.
Yeah, but if you explain to the patient, 2 groups, okay, here you perform every kind of chemotherapy, what you want. The other 3 cycles of your method, only 3, and then you check it with a PET scan and biopsy. And then if the patient progresses, the patient have been informed from the initial study, okay, we will offer to you everything. But we need one proof of evidence.
Yeah, maybe also the radiomics can help us, I think. No, maybe with the radiomics we can detect this change in the tumor and more homogeneously, not only in the point that we are biopsying, because the problem is that the tumor is really heterogeneous and you are doing the biopsy in a small piece of the tumor, so it's very complex. Another maybe way is the radiomics. I don't know. We will analyze our data from the baseline MRI and we will see. Yeah.
Yeah, I'm very much surprised that you cannot see in CT scans this very little pieces of particles. So I'm not surprised. It's okay.
You are not surprised?
No, I'm totally not surprised. But you can see perhaps something on the iron. You can discuss it, but at the end it doesn't matter, because what it matters is at the end you want to place some particles to make it more easy to apply to bring heat to a specific area. So whether you have nanoparticles there or not, it doesn't matter for me as HTA. The question is, can you place some heat there? Because if there's no heat, then it doesn't matter whether there are particles or not.
But in theory, the nanoparticles help us not to have the tumor heated. No?
Yeah, but the question is, have you applied more heat as normally without these nanoparticles? So by radio frequency or whatever. This in relation to nanoparticles. So if there's something or not, it doesn't matter. It's their heat is the question, first of all. Secondly, you are talking about pancreatic cancer. And I do not know what it is, because I know that it's an organ. It's an organ with different kind of tissues inside. And what you have at the end is what kind of cell is making the cancer in the pancreatic organ. And you have shown different kind of cases where I would estimate that it's not every time the same pancreatic cell-based cancer.
In theory, yes. All of them are adenocarcinomas, so all of them are from the ducts of the pancreas. Yeah, all of them are the same kind of cancer. Of course, every patient, every cancer is different, but yeah, in theory, they are homogeneous type of cancer. All of them are from the same cell. All the patients.
Because you have CA99.
No, it's because all of them are adenocarcinomas. All of them are adenocarcinomas, and the adenocarcinoma is the same kind of tumors. But of course, every patient is different.
Yes, pancreatic cancer has different subtypes. These 4 cases were all the adenocarcinoma type. Yeah.
Yeah, it's a homogeneous population. But then every patient, every tumor, it's a different tumor, different size, different grade of necrosis. So.
Okay, so we will take one question from the audience here, one more, and then the last one will be a question from the audience online that they will be waiting for a long time. So we will,
of course,
take that.
Thank you for the nice presentation. I'm wondering if did you study the degradation of the nanoparticles in the in vitro studies, like at cellular level, like by TM, etc., with different conditions? This is my first question. The second question is, how is the structure of the particle, the shape, the coating of these particles? How is?
So
maybe, I mean, in order to study the degradation, no, at the cellular level, it's really important to know this kind of.
Yeah, so maybe the part of the cells, I don't remember, no? Maybe the work package 2, no? You can explain better than me, yeah. Because.
So the iron oxide cores in a dextran matrix. We've done extensive work with preclinical models looking at the biodegradation of that material over time after it's had been injected into the tumor, and it's essentially a process of gradual metabolization. It tends to get caught up in the interstitium, or taken up in macrophages. And in the macrophages, it gets broken down inside the macrophages.
So I'm the work package leader for the physical chemical characterization on safe and medtech. And we have done quite an extensive amount of work under the ISO standard in order to comply with the regulatory requirement and the standards, in order to look also on leachable and extractables, in order to look at the components of the degradation and also the recruitment from immune cells and their potential polarization that it might happen. So we have extensively investigated everything preclinically, has been published. We actually work on 2 models under Nocanther and a previous project, which was called Multifund, where we also tested the particle in breast cancer type. So we did in 2 pancreatic cancer model, in 4 breast cancer model, and we had looked actually on the courses after 1 year injection into animal in order to see the biopersistent. And the results are all leading that it doesn't cause any side effect or any adverse outcome that could be trigger a pathway that could raise concern. We have also expanded even further into the genotoxicity, and we have looked at the hepatocellular uptake as well. So the process has been quite comprehensively done in vitro to be safe in terms of injection into the patients. No, it's down to the resolution of the machine versus the size of the particle. The particle are ultra small. Unless they aggregate into clusters, you don't get enough sensitivity from the machine to see, because the resolution of the machine is in the 500 nanometer to a micron in the best possible way. If you do a rapid CT scan, you actually miss it completely because it's above 10 micron. So you won't say anything unless all the particles you injected, they are all there. But the evidence we've seen in animal is that they disperse into the tumor.
Okay, so we are going to take the last question online, and then we'll have time during the coffee break to continue asking Teresa the question that we have in the audience. So online, Ranuka Maria Fartila was asking, I'm curious, why did you apply first the hyperthermia and then the chemotherapy and not the other way around?
So in the work package too, they did a lot of experiments doing all the different possibilities. For me, and this was the best, for me, it makes a lot of sense. So first you apply the hyperthermia, you change the characteristics of the tumor, and then you apply the chemotherapy in order to facilitate that the chemotherapy can arrive to the tumor cells. For me, it makes a lot of sense, but we did a lot in the work package too. They did a lot, or 3, I don't remember where, they did a lot of preclinical work trying to demonstrate which was the best sequence to give the hyperthermia to the tumor. No?
Okay, thank you very much. Actually, we did experiments in vivo comparing first animals receiving first the chemotherapy and then the hyperthermia and the other way around, and the concentration of the chemotherapy that was arriving to the tumor or staying in the tumor was much higher when you were first applying the hyperthermia and then the chemotherapy.
And it makes sense.
It makes sense, yes. Okay, so now we will go to the coffee break. For those of you that are attending online, we will resume at 11:45 following the agenda, the original agenda, okay? Thank you.
Thank you very much for the invitation. I appreciate very much the invitation now. Fantastic. Also the climate, the friendship, we were really astonishing. I'm enthusiastic to be here.
To move on.
Find out.
Okay, I am lucky because some slides have been already presented by colleague Contreras, and so it's easy for me to show and to take off rapidly this slide. This is a general cartoon that is in which you can see many activities that we believe have been performed by the heat. Many think, and honestly, we don't know exactly what happened and what happened to this. Anyway, you see, we obtain an increase of cell death, an inhibition of DNA repair, an increase of each shot protein. It depends which kind of each shot protein, but anyway, this is also cytokine. They move an activation of antigen presenting cell and so on, the migration in the lymph nodes, the production of activated lymphocyte and T, and other effects. Okay, we have on the market and in activity different type of local regional hyperthermia, isothermal, local heating, and non-isothermal heating. My experience is based mainly on capacitative and on this type of radiotherapy. Actually, I am not able to define which is the better machinery, the better activity. Every one of these treatments promote the heating of the region of the body, of the mass. But I am very honest, explaining you the reason for which hyperthermia is growing up is the pushing of the surgeons, because the surgeons have been developing HIPAC, intraperitoneal chemotherapy, and this group of surgeons very, very strong around the world, and they push all the activity devoted to hyperthermia. It's not a merit of radiotherapist or medical oncology, but the surgeon. This is what I have done. This is my treatment. The difference is that here the heating is not so defined and precise. Here is better because the tumor, the part of the body, is in a circuit, a radiofrequency circuit, so we obtain surely a better heating of the tumor, more defined, more precise.
Parts. In this cartoon, you see what happened, creating temperature gradient.
Okay, this is the activity that electro-hypertermia can obtain. There is many activities. You can see
huge temperature locally in microscopic region.
High
reordering the cytoscalar structure underneath the form of the cell. Red check enzymatic process and stochastic promotion structure under the form of the cell.
Lecture the enzymatic processes, the stochastic promotion, stochastic effect by term fractal modulation, this kind of irradiation, large gathering, beta gathering, cytoscalar complex, and so we obtain large dielectric losses, membrane increasing
and the fire gradient orient the broken adherent connection. Forming E-cadherin, beta-cadherin, cytoscalar complex, and moving the membrane flux, reducing.
Yeah, you can find a very recent publication in which the European Society of Hypertermia Oncology try to define the rules, the machinery, the technique, because the limit of hypertermia in clínica today, because we don't have any kind of rules. And if we consider the vast activity that have been carried out in private clinic, this is a complete disorder. So we need to have clear evidence for clear conclusion. This is the machinery that we use now. Recent one, very effective, is easy to define the temperature, time, and so on. This is the building of Sol in Spanish, so in English. This is the department of radiation and oncology, in which these colleagues perform about 30,000 treatments per year, and they adopt the different machines, and they have machinery online. How do you say? To treat more patients. This is our colleague Zelo Buraskovic from the University of Maryland. He is deeply engaged in hyperthermia. He sustained that the combination of hyperthermia mass linear accelerator and linear accelerator means to obtain a proton treatment. And if you use proton beam therapy mass hyperthermia is as using carbon ion. So you obtain a more destruction, more fragmentation of the DNA, so more difficult to obtain the rescue from the damage. This is the problem. The triplet program of Vujaskovic in Maryland. Okay, the action of radiation, you know, the action of hyperthermia combined with the immunotherapy anti-PD-1 drugs. This is interesting because, as told before the colleague, it's not easy to kill every cells in the body of the patient. Probably we are looking for a new way of thinking, try to destroy, but to induce an immune response to treat everywhere the cell. This is the program in Maryland. Okay, what we have? This is many studies in which the comparison is radiotherapy plus hyperthermia versus radiotherapy. All these studies have been considered for complete response and major responses. And you see that in different type of tumor, you obtain an advantages with the addition of hyperthermia. But what we have to consider is the evidence, the pyramid of evidence. Where is hyperthermia? Evidence one, randomized studies phase 3 is for soft tissue. I'll show you. Cervical, I have also evidence in bone metastasis, melanoma, head and neck cancer, thoracic recurrence of breast, rectal gliomas. Evidence one means that is a general agreement that a given treatment or procedure is beneficial, useful, effective. This is recommended or indicated. But even this type of treatment is recommended, indicated, is not applied because in Europe, in your country, in Italy, there are not the number sufficient number of institutions with hyperthermia. So the problem is that we cannot develop it. And again, is another negative experience is the thoracic recurrence, because thoracic recurrence was in American guideline and NCCN, and then have been taken off because only few centers perform it. Okay. Here you see the shared palliative clinical evidence from phase 2 studies. Okay, first is pancreatic, because today we speak about pancreas, but we have also some evidence in relapsed cancer of the head and neck, advanced recurring bladder cancer, rectal recurrence, already irradiated bone metastasis, visceral stenosis, palliative containing analgesic therapy. In soft tissue, this is the pivotal study, the crucial study that have been developed and published in JAMA. This is the RTC, ESHO is the society, RTC is the study group with a randomized trial, all European, generally North Europe. And it's clear, the advantages at 5 and 10 years, you see, disease-free survival, and this is clear, even if you consider the different site of tumor, because in the limbs or are better than in the abdomen or in the chest. Every group has advantages of radiotherapy, of the combination. This is chemotherapy plus hyperthermia, no radiotherapy. The conclusion and relevance is among the patients with locally high risk soft tissue sarcoma, the addition of regional to neoadjuvant chemotherapy results in increased survival as well as local progression free. Each parameter is in favor of that. This is a patient, you see the response of this group of Vermeulen. You see the clear reduction, and then the patient has been resected. This is a young boy, progression and poor response after only chemotherapy, other chemotherapy plus hyperthermia, a clear reduction. I mean, you had hyperthermia, you had response. The second problem was why this patient had such kind of advantages. Why? And so the same group had developed a new study about these responses. The conclusion of the study is that preoperative therapy reprograms a non-inflated tumor at baseline in an inflated tumor, I mean, with a lot of infiltrating immune cell. The post-treatment immune infiltrating became predictive of clinical outcomes. The patient who has the major inflamed tumor have a better response and survival. And the combination with regional hyperthermia primed the tumor microenvironment, enabling enhanced anti-tumor immune activity in high-risk soft tissue sarcoma. So this study is clear, evident, and is a proof of efficacy. The explication is, you already know some of these images. The explication is that the eating means activate innate tumoral response, natural killer, all what is innate in our body. Okay, a lot of a cascade of events, no? Natural killer, tumor exosome, activation, and so. Activation of the antigen presenting cell, and from here, the adaptive immune response. So this plus this. This is the activation, the production of activated lymphocyte, the increase of lymphocyte trafficking, the production of different substances, and this is the explication that they give for the brilliant result. Cervical cancer. This is pooled data in 2010. You see that the survival is clearly an advantage of the combination of radiotherapy plus hyperthermia. This is a clear study, a review. Cochrane is not so bad. This is a more recent 2021 review, recent study, the same result. So the combination of radiotherapy and hyperthermia is better than, okay, in this study, they use also cisplatin, a triplet. This is very interesting study, very interesting. This is the first study published on +1, you see, by a group of South Africa and Belgium, from Belgium. The study has been done with the more scientific criteria that we adopted in URTC trial. This is the first study. The first point is to see the responses at the PET-TAC responses. You see that the complete responses to PET-TAC is clearly in favor of the group treated with radiotherapy, cisplatin plus electro-hypertermia. You see. And another point very interesting is that in this poor patient, the diffusion of HIV virus is in the population is very diffuse, no? And so it's very interesting because patient positive for HIV had the same responses that the other patient without the HIV virus. So this means that there is an action that is on the tumor, not only mediated from the immune system. And we don't know if the patient with the HIV virus they are more active or less active from a immunological point of view. Okay, after 2 or 3 years, they checked the survival time and the period free. You see, after 3 years, the patients who received hyperthermia was clearly better, significantly respect no hyperthermia. And again, the PFS is similar, is maintaining in the time. This curve initially depended at 6 months, a number of patients was with persistent tumor. And so this is the calculation. This is a patient. You see the complete response at PET. And this is very, very interesting for the from an economical point of view, because this group study the quality. That quality is the quality of life for years, life of years gained, and this permit the save money for the health system. You see, the vast majority of the patients have an incremental quality because this is the cutoff of the cost that in South Africa they consider. The vast majority is under. So the public service and the private sector of South Africa that is engaged in the joint save a lot of money and treated a lot of patients. Bone metastasis, this is a simple study, very simple. At 180 days, you see that the patient treated with radiotherapy plus hyperthermia is very best respect the patient without hyperthermia. This is a very simple study carried out by Asiatic group. You see what some responses, no pain and calcification. But it is important, the method, because this is a randomized one. This is important. At the neck, okay, the neck was one of the first type of cancer treatment. You see that we have a lot of results from the end of 80. All is favorable. All is favorable. This is radiotherapy plus hyperthermia. This is for more recent trials, which a large number from Asia. This is from Mumbai. You see more than 300 patients. You see 3-year survival. Overall survival is 50% and 70% with adjunction of hyperthermia. This is significant. The same PFS. The same also these studies. You see. Melanoma, I put inside this because this is a clear study, a pivotal study, a fundamental study. And this study has been carried out by Overgaard, that is a famous radiotherapist, many years ago. You see, very simple study, 3 fractions of radiotherapy over 8 days, followed by 1 hour with hyperthermia at the target therapy of 43. Very, very simple. What happened? Complete remission, 62%, about the double. 2 years tumor control, 28% versus the double. This is what I see. Lancet is a good journal, and so I think that this is fundamental and it's necessary to think again to consider this data. The same at Duke University. They try to reproduce the same study. And 10 years later, they treat the patient. The vast majority was melanoma. We have melanoma patient. You see the same result. Okay, overall survival after 2 years, 3 years will overcome because melanoma is not only organ. But this is a crucial point. This hombre es muy feliz porque resolve el problema. This man received a treatment, the radio hyperthermia The result is very significant. Rectal anal cancer, we have many results, but I stress to you the study of Ott from Germany. This is a perspective randomized study. The number of patients is interesting, more than 100. You see 5-year survival, 96% versus 75. Disease-free, 89 versus 70. Local recurrence-free, 97 versus 80. And colony-free survival rates, very important for the quality of life of the patient, 87 versus 69. Other studies very significant for responsiveness. This is another study by Schroeder recently, a randomized study, prospective study, more about 100 patients, and there are some differences in overall survival, less in the other point. Okay, here we have a lot of data from radiotherapists, because they treated this patient, a lot of patients relapsed after surgery and radiotherapy. And so if you have a relapse on the chest, you cannot treat with a high dosage of radiotherapy. You see that we have some prospective randomized trials. A complete remission is 20% in this Japanese study. And please note that the high response rate that we have in this study, and Alberg, a large number of patients, you see a complete remission, local complete remission, 80%, with a significant median of 3. Obviously, breast cancer need to be treated with further treatment, so the survival is not well evaluable because the patient receives many treatments. But the result of that, very interesting. Gliomas. This is the first randomized study to permit the approval. The approval of FDA administration, Food and Drug Administration, for the use of hypertermia in glioma. This is the first study, is in 1998. And this is a more recent study. I would like to present my data. This is recent. I observed, my study was an observational study on 164 patients, 114 glioblastoma, 50 astrocytoma. Of this patient, 29 glioblastoma received electro-hypertermia, 28 astrocytoma received hypertermia. The other, what do you want? Every kind of therapy, second, third, fourth line of chemotherapy, analgesic therapy, holistic therapy, what do you want? The responses was advantages for hypertermia, and the survival was better at 2 years for astrocytoma and glio, but it's better to see the images. This is the study you can have, is free on internet. This is better to see, to understand what happened. This is overall survival in the astrocytoma group. This is the patient. A clear advantages for the patient who receive hyperthermia. This is for glioblastoma. Okay, it's not so clear, but there is a statistical advantage that the same. And the case of interest is that a large number of patients receive also temozolomide. And we see that the patient who receives temozolomide plus hypertermia has a clear advantage of survival respect only temozolomide. This is a patient from Salzburg that arrived in Italy for the tumor. This is before, this is after 62 treatment with electro-hyperthermia. But I am honest with you, I don't know the histological type, because no neurosurgeon tried from the biopsy to risk for the patient. So I don't know what is this tumor. This is a tumor with relapsed with a reduction. This is interesting story because from a human point of view, because the gentleman, okay, sorry, but it's possible to take off this or not, please. The superior. Okay. Okay. Allora, this gentleman have been treated for astrocytoma grade 2, not the worst. 20 years ago, from here to here, and under my here there is actually last year. No. Okay, stop here. Okay, you believe me. After that, I wrote a healing certificate, and this gentleman adopted 2 children after 20 years. The other one is a Joven Pintor, is an artist, not so lucky. And I can go. Okay. This is an astrocytoma with a clear reduction. This is the other gentleman, a young one that survived 5 years. This is a astrocytoma grade 3. This is a glioblastoma. You see the relapse tumor. And we obtain a clear response with hypertermia, electrohypertermia, lasting 6 months. Pancreatic now, the topic. You know that is an increased tumor where the population is older, lifestyle, and so on. My paper will be devoted to stage 3 and 4. You know that the vast majority are from ductal, pancreatic ductal, less than 5% here from the neuroendocrine. Okay, this is a good point, crucial one. We have already heard the problem. There is like a capsule against the tumor, proteoglycans, collage, fibroblasts. Inside this barrier, there is the tumor pore vessel. You see that there is no good vascularization. This is a barrier for the treatment. You see what happened, what offer hyperthermia and radiation on the vascular, on trauma, on immune response. These are already well-known information that you have. This is a typical classical image because hyperthermia can act directly on pancreatic cancer stroma. And this is a new thing that we have recently gained, because before we didn't know that there is the activity on the microenvironment. Okay, you have the same evidence that we have already discussed, and so I did not repeat. But this is the crucial what hyperthermia can offer us. Now, this is a wide review, systemic review carried out by Astrid van der Oost from München Hospital, Alemana, Germany, and they studied and defined more than 1,000 studies devoted to hyperthermia in pancreatic tumor. And the conclusion was that hyperthermia added to chemotherapy, to radiotherapy, may positively affect treatment outcome for patients. However, the quality of the review studies was limited and future randomized trials are needed. So what I told before, we don't have clear evidence of the efficacy in this tumor. This is more recent studies that are not included in the review because are after the review to our study from Sartre, my co-worker and myself. This study are in favor of hyperthermia, but it's not randomized. And this is the last published yesterday. You can find on internet, I think, in this day. This is is not a randomized trial. This is a multi-center retrospective of comparative observational study in which we collected the patient with stage 3 and 4 and that were treated with modulating electrohyperthermia alone or in combination with chemotherapy in 20 years. 20 years, okay, is a limit because it's a very long period. But anyway, a total of 628 patients were treated in 9 Italian hospitals. 17 of them were included in this study. 89 of them received modulated electrohyperthermia and chemotherapy, very simple chemotherapy, not EV chemotherapy. 128 were treated with chemotherapy, second, fourth line of chemotherapy, FOLFIRINOX, ABRA, and gemcitabine. What you want the best today? Chemotherapy was, in the vast majority of the patient, gemcitabine-based regimens. How we perform this? We perform using this machinery, applying a radiofrequency current of 13.56 megahertz as carrier frequency at the modulated by time fractal fluctuation. The energy was transferred by capacitive coupling with side impedance matching. The hypertermia protocol included 3 treatments per week for 2 months, starting at a low doses for time and power to see the tolerance of the patient. And following treatments were performed, increasing the power up to 150 watt and up to 90 minutes. Modulated electrohyperthermia was administered after chemotherapy or within 48 hours in order to couple the high drug blood concentration with the modulated hyperthermia. I mean, we have the drug in the blood, and so we okay. The sites of metastasis in the group are similar: metastasis in the liver, peritoneum, lymph nodes, not significant. Previous treatment. Previous treatment. The patient here you see the patient had 79% of patients in the hyperthermia group received previous treatment, 56 in no hyperthermia, significant. The vast majority of patients received chemotherapy, mass in the modulated electrohyperthermia group, respect no hyperthermia. This is significant. I mean that the patient treated with modulated electrohyperthermia was a little worse than the other, because this is not a randomized study, and the clinician sent us the patient when the situation was more compromised. Overall survival was 20 months versus 9 months for the patient receiving hyperthermia. Progression-free was 7 months, respect 5 months, both significant. Overall and PFS were better in the group receiving hyperthermia. The tumor response at 3 months was available for the vast majority of the 2 groups. And the patient treated with electrohyperthermia showed a higher response rate, partial response rate, 45% versus 24, and a lower number of progression, 4 versus 31. And both are significant. Stable disease was similar in two groups. Median section was 16.8, and we treated 4,500 delivered session of hypertermia. This is a table of responses. You see that this is highly significant. Adverse event was skin pain, very limited, 1.5%. Limited burns in 1.1%. And modulated hypertermia did not increase hematologic and hepatic pulmonary toxicity due to chemotherapy, and particularly no increased blood pressure or other cardiac changes after adequate cardiological monitoring, because this is radiofrequency, the position is that, the heart is up, and so theoretically could be happen something in that. This is survival. You see the advantages, overall advantages. The PFS still significant. I read more interesting because there was a difference. There was a more difference in the survival time in patients with less and more 70 years. Here, you see. This is very important because this means that hypertermia works in patients more frail, more older, and that cannot sustain strong chemotherapy. On the contrary, patients in the group no hyperthermia with less than 70 years, better than the older. So there is a clear advantages for hyperthermia in total and in age, advantages. Now I'll show you a case that a male, 50 years old, this is the stage of a tumor, BRCA mutated. The treatments were 3 times a week, power 104 watts, 60 minutes, plus capecitabine. Capecitabine is an oral drug. The responses in advanced pancreatic tumor is from 0 to 5, 6%. Treatment given as second line after a progression of the best treatment that we have, one of the best, that is Giammaria. This is after, at the beginning, basal, after 3 cycles, 6 cycles, 9 cycles of capecitabine and hyperthermia. The same patient, you see all the section, and you see a clear evidence, very, very good partial remission.
Here, after the drainage, you have a clear reduction of the tumor.
Drainage, after the drainage, okay, you attain response. This is the patient, and you see that there is a response also here. This is not my patient, not mine. This is from Kosen University that is in South Korea. You see that what happened? The tumor regression and the metastasis, partial regression after 42 times of hyperthermia, only hyperthermia. Take home message. The addition of modulated electrohypertermia to systemic chemotherapy improved overall in progression-free survival and local tumor control with comparable toxicity. On the basis of the study and the other numerous studies in the literature, it now seems time to organize an international randomized trial to evaluate the utility of electrohypertermia in this serious disease. This is some trial that is active in Germany, South Korea, Texas, Swiss, Berlin. And this is the conclusion that I wrote in Spain. We have evidence of beneficious clinicals or advantages in some randomized studies, sarcoma, tumor cervicales, metastasi ossea, mama. Evidenza clinica, the good palliation without any effect is muy importante, is very important for the oncological radiotherapy unit to have a very simple treatment, low assistance. It's not important that the doctor or the radiotherapist stay here on the patient to see what happened. Is necessary only in the beginning of the treatment to put on to define the field of eating, and then the nurses will do it. But quality is very favorable because we have an increase of good quality of life and low expenses. For this kind of machinery, no shield around the room, no protection is necessary. The patient accepts very well hyperthermia. Okay, as I already presented, accelerator linear plus hyperthermia given advantages also for protons and ion carbon ions. Chemotherapy and hyperthermia, you gain about 2.5 times in activity, and hyperthermia plus immunotherapy is in a new wave of research probably in the future to control these diseases. We hope that the results of our study will orient the scientific community to perform a prospective randomized clinical study to further define the efficacy of the electrohyperthermia in pancreatic cancer. This is Florence by night, the Palio of Siena, the Tower of Pisa. I thank you very much for this organization. Organizamos siguientes estudios.
Okay, thank you very much, Giammaria Fiorentini. So now, if you agree, we will have the round table, and Dr. Fiorentini may take the questions that you may have for him in this round table. So I invite now to the table again to Álvaro Somoza, Jorge Corrales, and Daniel Ortega. And the discussion now will be led by Adriele Pina Melo. So I will pass the microphone.
So, thank you. As we are wrapping up the first part of the day, and I'm gonna squeeze the sugar that you have intaken during your coffee break before you start craving for lunch. So we have about 45 minutes between the online attendees and you to actually do a kind of a exploratory roundtable from what we touch base. And I'm just going to summarize randomly between what I heard today. Preclinical translation, we have Alvaro that has a wealth of experience. Clinical use of hyperthermia, new biomarker. We have 2 oncologists that can give us the input. MPI and detection of particles and the need for visualize them for evidence, as from the regulatory side as a potential input. So we have 5 questions that can fire. Second point that came to my mind is the order of the list. As you do shopping, you shop first for grocery or you shop for your frozen food. And the same here is, do we do hyperthermia before chemotherapeutic or we do chemotherapeutic before hyperthermia? What is the preferred way to do? Okay, and I apologize for the analogy. I'm the one shopping in the house. That's why I'm using the analogy. But the view there is, I just like to steer everybody, because during coffee break, I had a conversation with some of you that approached me from the clinical, but also others from the clinical. So I think you have the opportunity now to come. So I tend to speak too much. I'm not gonna talk anymore now. So floor is yours, please. And I'll be running around. And so first and foremost, as the project No Cancer has been at the basis of the results that are being presented today from Teresa Macarulla and from Ivane, is Alvaro Somoza, who was the coordinator of the project of No Cancer. And we own a great deal from his availability, but also on the opportunity that he brought all the project to the clinical investigation. And he spent endless nights to try to put together all the information to ship material to everybody as well. So Alvaro, do you want to say a few words about No Cancer and the opportunity that No Cancer opened?
Sure, thanks. Well, as you said, I was the coordinator of this project, No Cancer. I think you saw some of the results that we got, the clinical result. I think that's the final aim of course of the project was that, but till we got there, it was a little bit difficult. And I think one of the purposes of this roundtable is probably discuss or talk about the issues that we encounter in this journey, and of course learn many things. And of course, if I had to start over, I will do it differently. And I think that's something we all learn about that. But I want just to highlight a few things that maybe you are aware in a way, but I think it's good to say here that to address this kind of tumor, or probably any tumor, it's good to have a multidisciplinary approach. And I think it's this thing that we did in No Cancer and in most of the projects that try to treat cancer, pancreatic cancer and all cancers. But the thing is, when you are dealing with this multidisciplinary approach, you are talking with many people with different expertise, physicists, engineers, MDs, biologists, and so on. And it's exciting, but also sometimes you have to be aware that everyone speaks probably a slightly different language, or at least a different accent. And that can be problematic, and that can be something that as coordinator, I had to be aware, of course, and I had to sometimes translate the things. And what I want to emphasize this, because sometimes the problems are coming from that, because we as scientists in our field, sometimes we try to oversimplify the problems, and because it's the way to advance sometimes. But we have discussed this in today. Probably you don't realize, but this issue of the what kind of pancreatic cancer are you dealing with? No, what kind of cells? That's true. So each cancer is different. Each pancreatic cancer is different. But in the same way, the nanoparticles that we are using, the term nanoparticles, probably too general. And this is the point I want to stress, that we have seen a lot of results here from nanoparticles. But nanoparticles is a general term. The core is different, the shape is different, the size is different, the coating is different. So every result that we have seen here today is from a different particle. And that is something that I found is difficult. We have to find a way to homogenize all these things to advance, and it's something that sometimes is difficult. So I wanted to stress this thing. And also other issue is that we are dealing with let's say, a not traditional, it is not traditional. So we know we have all the expertise from companies, from different groups using, let's say, standard approaches. So the animal models per se, in a way, have been evolved or have been tuned to work better for, let's say, the traditional approaches. But now with nanomedicines, we are facing this problem, because probably the translation to the clinic, probably the animal models are not perfect for the application of nanoparticles, and it's something that we have to be aware. So in our travel, in our journey, probably the main problem, I wouldn't say a main problem, but as I said, might be just to know completely, you have to know the final goal and involve all the people from the beginning, and this is not easy. So when you write the proposal, you have all the people thinking in the task. So you write the proposal, probably everyone has clear what is going to be doing in the project, but everyone have the whole approach, the whole project in mind, because otherwise it's going to be a failure. So for that, what we did at the beginning was to involve, for instance, Teresa and all the clinicians, the people from the translation, because we need to have that information. And indeed, during the project, we have to tune the project different aspects based on what the clinicians were telling us. Even if the activity of the clinician started at the end of the project, they were very, very, very well involved. And that was critical. That was critical. And I want to thank that because I hadn't much experience dealing with clinicians. And for me, it was really nice to have your involvement. And your involvement in the preliminary phases, when you weren't doing, let's say, nothing relevant at that point, but it was key. And that's something that you have to keep in mind. So if you want to get to the clinic, you have to have all the clinicians in the beginning, even at the almost the synthesis of everything, even if they sometimes they don't, let's say, they don't understand or they don't see the value of that. It's very, very relevant to have them. So have the clinicians, have all the people from the safety involved in that project. And I think that's probably my main message. I think it's enough just to start with. I'm going to stop here.
So to add to Alvaro and for everybody here, just wanted to let you be aware that the journey took 11 years. We started with a project which was called Multifam, and we didn't have clinician involved, but we progressed in the preclinical platform. The Commission realized this one through the round of funding because it was European Framework 7. Under Horizon 2020, they put together a pool of money for the initiative, which is also represented here today, which is called Open Innovation Testbed. An Open Innovation Testbed is a portfolio of opportunity where a customer or person who wants to develop something in the health space can approach the organization for assisting with the clinical study. Not everything is available and not everybody is lucky like we have been to be funded under the European Commission. So the Open Innovation Testbed are there to support the process of the readiness, the preparation to the clinical investigation if the product has success. And this is what is Safer Method, which is this logo here. And this is what we are representing today as well. Several of us, Ivana first, then we also have Valdebron, we are lucky, we have Luke, we have Quentin, we have also touch base. Why for the development of a product to reach a proof of concept, a proof of principle. Okay, so that's where we can engage with the oncologists, and that's the point that Alvaro made very clear. The dialogue has to start as soon as possible, as also the dialogue with the regulator.
Yes. So indeed, of course, we have a meeting with the Spanish agency just to start the discussion.
Yes. And we touch base on that later. On that aspect where there's going to be plenty of discussion. But if I can throw a question to your side, to all the four speakers. Giammaria, you mentioned the aspect of being, the evidence has to be clear, especially when you go to phase 3 and you iterate this one. Jorge, you also mentioned the aspect of the fact that you need to see and to distinguish where the hyperthermia provide benefits. And Daniel, you provide the basics and the physics behind. And with no cancer, in your view, where do you think hyperthermia as a new alternative method should promote further the feasibility side as a technique? So we say radiotherapy is the common path. And you work very hard. You present example in the Spanish way, how it became here the main change. How could you put it forward? Because, for instance, it's not a trivial way to bring into a system that is very much made in surgical procedure. I like a quick answer from all your stuff. While you prepare a question, because I didn't see anybody raising your hand, by the way. Oh, I knew that you were there. I'll first like to hear your comments.
I start. I think it's very important to go in three directions. First, to expand the knowledge and the experience with the professionals. It's very important that the oncologists, the clinic and the clinician oncologists know what we are doing and what are the evidence that we have now to recommend the hyperthermia. This is the first step. Second step is very important to promote to the general population, because sometimes the things change when the patients demand a technique, and this is very important. We have seen with hepatitis and with treatment for different diseases. And the third leg is that it's very important to get funds to promote the research, because the problem with hyperthermia is that we don't have the same money to invest as with the pharma. So it's very, very difficult to develop different projects. From my point of view, I think that we have done a lot of very good things, but we are doing bad things with the hyperthermia, because we are in the dark side of the patients. We are admitting all the worst patients to be treated with this technique. Sometimes it's impossible to obtain good results in this situation. So I think that we have to work together, all the actors in this picture.
Who's gonna take?
Yeah, so I fully agree with Jorge's comments, and it's to my mind is very important, because in the case of magnetic hyperthermia, there have been so many little studies everywhere, but without connections. So it's difficult if we do not create and sustain stable research communities around this of the world. Perhaps some national groups, but they must be stable, and they have to build new knowledge on what
Study to organize a round table to encourage the could this be a start? You think that could work? Connected to what you're saying.
Yes, of course. There are already some studies to place in the country, not only in Europe but also in the Asia and States. But there's little connection. If you look elsewhere to other medical specialties, so the structure is absolutely different. So there's always solid communities working together, and this is not the case so far. So hopefully this will change in the near future. But yeah, of course.
Alvaro, we started from the magnetic and scientific clinical application of nanocut, our journey. How would you see compared to?
Yes, well, I want to add additional things. So what is the hyperthermia? So, but what is the expertise that you need to apply that? So now, in our case, we need, of course, an oncologist, but we need, of course, an endoscopist. So that there are many disciplines involved in the different areas, and it probably is something that is complicating this connection, because who is going to lead that? Everyone in the field. I mean, the oncologists, the radiologists, the endoscopists. So who is going to attend this thing? And that's probably what is the reason behind this lack of connection.
And Giammaria, in your experience?
Yeah, I agree with the colleague. One of the problems was that the cooperation was poor, because I remember that in late 80, late 90, the hyperthermia was the third pillar surgeon, radiotherapy, surgeon, no, the fourth pillar, yeah, surgery, therapy, but the colleagues of the North Europe, mainly in Holland, Germany, they are strictly linked with the temperature. If you cannot perform the temperature, hyperthermia is not hyperthermia. Out of this door, we are not an hyperthermist. Only what we are doing is real. This is a problem, and this is for decades. This problem actually is moving the situation, because we know that hyperthermia has not to be top 44, 45, very elevated. Okay, radio frequency, we need allow radio frequency is other thing. Probably we have advantages with a limited amount of energy, with a limited amount of hyperthermia. And this is a new field, a completely new field of research. And so we have to go in this field of research. And probably if we're fighting with nanosphere is the top, can cure the cancer. If this is a message, this is wrong and we will fail. Probably we have to show that can be utilized in some stages well defined, in some combination or in some position of the treatment, because we have a continuous of cure in the tumor. Out of mind that is possible to have one thing that can sufficient for the solution of the problem. So to have money, to have support, we have to define a political strategy, not only with other colleagues, but with the mentality. And again, we have to, in my opinion, to try to join some relationship with the big pharma that are producing the new drugs for immunological system. Because if you contrast this, you will be take off from everywhere. The reality is that this activity is a little bit weak respect to the other actors in the field.
If I may add something to Giammaria, I completely agree. The problem is sometimes when we discuss with our fellow colleagues about the temperature, I always answer the same, because when I plan a treatment for radiotherapy, I know what I have planned, but I don't know exactly what the patient is receiving in this moment in this patient. And the same with chemo. When you give a cisplatin, the distribution in this exactly patient. So when we discuss that we have to prove and to test the temperature that we reach with the hyperthermia treatment, and I would like to know, but it's not exactly strictly necessary, because you have tested and you have preclinical researches, and this is an answer. It's as, for example, when you have to test the enhance of the response with 5-few, but when you use HIPEC, you are using HIPEC because it's more effective, because you are giving hyperthermia with the chemotherapy intraperitoneal. So you can I don't know if there's a word, you can extrapolate the situation, because this is a physical technique. This is not a drug. We have to test and to prove everything. I agree, and I would like to do. But you can extrapolate the results in different situations.
Okay, so thank you very much, Adriele. In fact, I was going to ask the general question that you then asked, but I have another question, which is that we have in hyperthermia treatment so many different targets, so many different cancers, so many different modalities. We've also got so many different ranges of temperatures. We're talking here mostly about mild hypothermia, but there's the thermoablative range, where you're talking about 70 degrees, say, and then everything in between. Are we being one size fits all, trying to do too many things? And is there a strategy that would be more sensible to try to gain traction and to create this position that we would like to see of the three pillars of chemo, radio, hyperthermia? And should there be thermo-oncologists as well as radiation oncologists and oncologists?
I agree. So yes, I think you put it clear, no? So it will be necessary probably. So you mentioned that there is not many experience, or we are gathering experience about thermotherapies, and maybe there is a new specialty coming in the future, focus on that will gather all the information, all these clinical trials and so on. I think that will be within one thing, and one a general problem for everything, and at the end we have to go for the personalized medicine. And as you mentioned, so we don't know exactly the dose, so we don't know exactly for this patient what he needs and what he's getting, and I think we need to go for a personalized hyperthermia. Maybe we need the probes that people are developing to quantify the temperature that they are getting each patient, to finally quantify everything. And probably, I mean, I'm not the MD here, so probably you should define these issues in more detail, not myself. No.
Talking about the same thing, but this one size fits all. I think if, for example, in the case of magnetic hyperthermia, is particularly suitable for deep-seated tumors if compared with other modalities, tissue dependent. In the case of when you are applying an electric field or you have microwaves, etc., you're relying on the physical properties of the tissues that you are going through. So, and this is not the case with the, or not so, with the your target is where your particles are actually, and everything in between, it's not so, yeah. So so I think that could be like the direction to walk through. So it's like developing magnetic hyperthermia, keeping in mind this, it's suitable for deep-seated tumors that could not be safely treated with other modalities. So yeah, and I wanted to say something before that I couldn't. So in my opinion, it's so there's no clinic in the case of magnetic hyperthermia. There are no clinical evidence, not so many clinical data, not so many clinical studies, trials, etc. And you need, for that, you need two things. You need the people and you need the money. If you're looking for money, you have two different sources. You have public funding and you have private funding. Forget about private funding because there's no such an industry based on magnetic hyperthermia. So we go down to the and you see, where's the big money? Big money is there any funding strategy over the years? There's no such a thing because the European Commission is just listening to people on the topics that will be interested to fund at a particular time period. And you have to sit and wait for your turn. You know, when there's a call for topic that you say, hey, that could be for us. And there's no way to develop anything, you know, based on that. So I think this is sort of like a vicious circle where we are in. So we have to find a way out of this.
I think I don't agree in this. Sorry, I have my view on this, and I have indeed to say that in this particular case, we are an example of what the European Commission did. So it started with multi-fund.
Just once.
Yeah, well, but I think, of course, once, but
yeah,
it started with multi-fund, then no cancer, and then Safe MedTech. At least it supported all this. I understand that there is not a continuous way to fund, but this is not the policy of a European Commission. Is they want to innate, no? They want to start things, But
Ivana made a very good comment to you, Daniel, which is like, what about the people? In the meantime, they change job because they can't get the funding. So they actually change the topic. So while I'm encouraging more questions, I see Hans Peter has a question, but I would like to have a question for this part. If you want to balance this table, because they ask me questions and this part of the table doesn't answer.
I have thousands of comments because I'm a public agent working for the Commission, working for the federal government, working for many organizations as Euroscan. So I totally disagree with what you have said about
disagree.
Absolutely, it's
okay.
Totally.
Thank you. That's good.
The other way around. The topic I wanted to raise more or less is: when you said we need more specialists, do we now need also magnetic hypothermia specialists? You want to have more specialists? Is magnetic hypothermia, as you describe it all the time, the same as hypothermia in general? Do we have something similar? Is it very different? Because you make differentiation. Yeah? And that's why my question was, is it a mechanical issue which appears with the nanoparticles, or is it just the heating topic which is here of importance? If you come to reimbursement organizations, honestly, at the end, it doesn't matter for me. Because I believe the patient has a benefit. So I'm more or less interested in where is the overall survival time? How is the quality, not the qualities, the quality of life of these patients who are suffering? Because I was very interested when you described that the patient is coming from Canary Islands every time to Barcelona is flying. I think many people are suffering. So so the patient in some way gets support. Is this something good? Is this a supportive treatment or is it a treatment? By business, you have to define endpoints, primary endpoints for reimbursement organizations, but also for regulators, how to describe the clinical benefit of the therapy. This is also important because we have side of concepts, but also then how to find the endpoint. What are the most important endpoints you see in the next studies have to become? Because I've written also down 2,000 studies. One said we have enough evidence. Others said we have to have more money for more studies. It sounds to me that the number of studies is not reflecting really the quality of this, of the therapy, what we want to achieve. And perhaps less studies with more money inside of each study could do better results. Question mark?
I have a comment for you.
No, only about these endpoints. I think one thing is you have sometimes your endpoints in your mind. What do you want to see in these trials? And then the regulatory agencies ask for other endpoints different. And sometimes they want survival. And of course, you can add quality of life and other endpoints, but at least in oncology, they ask for survival. And sometimes it's very, very difficult to demonstrate survival in this kind of strategies. Yeah, that's like a secondary endpoint, but that quality with the quality of life in this moment, in oncology, nobody is doing nothing because only with quality of life. Of course, it's something that you have to include in your trials and in your treatment approaches, but different thing is what regulatory agencies ask you need to achieve in order to transfer your options. So sometimes it's
So Maria has a question for you.
No. A comment for a colleague. Okay, we need to save time, so we have to think a combination, clearly combination, easy to do for develop what you have just told before. Well, in the vast majority of our hospital, the most important and powerful doctors are the surgeons. They are like lions in the jungle, no? doctors. In Europe, we have a very important group in your country, in Spain, France, everywhere now in the Western countries, that perform, as I told before, intraperitoneal chemotherapy after I've removed all the tumor. Now, the novelty of this field is PIPAC. That means pressured intraperitoneal administration. Means that they perform a very limited cut in the abdomen, and they put inside like a pump and push inside gas and drugs. Should be easy with these people that will already know hyperthermia, because they already have developed in 20 years hyperthermia in the abdomen after reduction, to convince them after the demonstration of the animal model that the toxicity, the dose, everything to do, that is possible to add to PIPAC hyperthermia produced with nanosphere. I am sure that they will accept, because this group are looking for that, how to increase the result. They believe in hyperthermia. This is advantageous because you select the doctors and the centers, I repeat, very strong, like the lions in the jungle, respect minor subjects in the hospital. Sometimes medical oncologists are not so strong, other colleagues are not so strong. This is very strong. They have a lot of publications. They are looking for new solutions to use in the abdomen. I think that this could be the link that is possible to organize in few days with this. Also in Barcelona, you have a very famous surgeons for that. So I mean, advanced patient is not possible to make operation. It's not possible to perform IPEC, but you offer them a PIPAC plus hyperthermia with nanosphere. This should be an idea for the future.
So I'm going to make a question now for Contreras, Corrales. I'm changing your name constantly.
No problem, no problem.
But the question is, you show a very nice map of Spain.
Yeah.
And there were just 4 cities in the whole Spain where the hyperthermia was being used. So is this because there are some key professionals there, some key radiotherapists or key physicians that are pushing to do that? Is this because the hospital was having like a clear strategy of implementing this kind of therapy? Was this because the local government was putting money to do that? Why was that?
In Spain, the technique is implemented because of the professional of the hospital. You have to fight against the hospital to introduce the hyperthermia in the clinical assistance. But I have shown only the centers that are implemented in oncology department. For example, in Seville, there is a new center in Quirón, Seville, with they are leading the project medical oncologist. So I think that now the technique is very professional dependent. If you don't have the interest, the ability, the dedication, it is impossible to move forward and to implement the technique. And I am happy today here because if I compare the situation when I started in 2014, it is completely different. And the scenario is completely, for me, optimistic. But the problem is like the blind, when you can see something, you say, okay, I want to see everything. No? And we have a lot of things to do, but today I think we can leave the message that the situation is positive, at least in Spain, because the regulatory agencies are waiting for the response that we have presented the report in the National Health Service, and also with the reimbursement for the private sector. I work also in the private sector, and 2 companies are reimbursing now the treatment with hyperthermia in several indications. This is very, very positive, because the effect of contagious effect is very, very positive for the technique.
So you said that well, now we get to the point where the people is very important, because those were the ones pushing. But then how can you, when you were discussing whether this has to be thermal therapies or radiotherapies, and then when Giammaria was saying that the middle eastern surgeons are very, very pushing and not that much in radiotherapies, how do you see that being a radiotherapist yourself? And do you think that the radiotherapists should be the ones leading the project, or having a more established hyperthermia in the whole Europe, or it's just the community? But who are the key people and the key persons in that community?
This is a very, very interesting question. I am going to be very clear. No, it's necessary to be the radiotherapist or the radiation oncology who lead the project, because I think that hyperthermia is a technique that should be done by an oncologist, a person who knows everything related with the cancer. But the problem is that in some countries, and in Spain as well, some physicians or not physicians has recommended or prescribed hyperthermia without knowing the problem of cancer. And you have to combine the hyperthermia with the conventional treatment. It's very important to know and to be informed about the treatment of oncology. So I think that the future of hyperthermia will be an oncologist prescribe the treatment, and probably it will be administered in a radiation oncology department or whatever. It's not important, because in my case, the nurses and the technicians are who give the treatment. I only prescribe the treatment. I am not follow the patients and treat the possible side effects, but the flow chart shouldn't be inside the radiation oncology department. But in Spain, I'm trying to exploit this situation. We have this inside the program of the radiation oncology specialty. So that's my card of presentation with the administration, but it's not necessary to be inside one specialty.
And then in your opinion, also in Giammaria's opinion, is there any type of cancer where this should be like pushed a little bit more? Like, for instance, Daniel, you were saying that for pancreatic cancer, magnetic hyperthermia should be the way to go compared to other type of hyperthermias. And then you were suggesting earlier this morning or yesterday that probably tumors that are more accessible, because they head and neck tumors, could be also an option for magnetic hyperthermia, because then you can localize that, or you can inject much better the nanoparticles. So I don't see that is a clear indication for magnetic hyperthermia or for hyperthermia in general. And this is putting a lot of noise also, because sometimes the experiments or the clinical trials are not that homogeneously designed, and then taking the conclusions out of that is difficult. So I was wondering, really, there should be 1 or 2 or 3 or 4 indications where the society that you may have on hyperthermia should push a little bit more to have those progressing better in the overall progression of it.
Yeah, I agree, because you have to use the hyperthermia in those situations when you don't expect to get good results. But to start with and to make regulation, it is makes sense to start with 2 or 3 indications and to get experience and publish the experience. trying to convince the rest of the community. But this is like we compare the hyperthermia with radiotherapy or with chemotherapy. Where can you use radiotherapy? In all the tumors, but some tumors better than others. This is the same because we are trying to enhance the response of the rest of the treatments. So I should use in the situation that I don't expect good results. Where? Pancreatic cancer, advanced head and neck tumors, glioblastoma, cervix cancer, probably rectal and sarcomas. These are the situations.
Adriele, do you have a tracer? Do you use a tracer to identify where the nanosphere are going?
The nanoparticle.
Nanoparticle.
You can use a tracer, but in preclinical you can do any type of modification. But when you go for a product that is going to be in clinical, it has to be on the final formulation. So you can't use it unless you can use a technique that is sensitive enough to detect the particle. And we have example with Quentin that he has done it, where you can actually develop a probe that is kind of like a magnetic wand that actually vibrates when the particle are. But that's a superficial detection. So I'm acutely aware about time. Also, we have a power trip, so people disappear from the screen, they're still probably there. And I'll take the question from this side because we need to balance the two sides of the table.
Well, thank you so much, all of you, for the magnificent presentations. I have a question for you. Apart from the matter of the temperature, that the people say that there's no always a way to know exactly the temperature of the tumor, is there any other reason why hyperthermia, knowing that the evidence is so solid, why it's not so developed in Spain, especially in Spain? I mean, because in Italy and in the north of Spain, I know hyperthermia is well known and is well established in the country and in the sanitary services. But especially here, apart from the temperature, is there any other reason for it?
This is a very good question that I have been asking me during the last 10 years. No, the problem is in Spain, we have a problem with hyperthermia because some alternative centers has used the hyperthermia for treating the cancer without the conventional treat. So most of the colleagues don't know anything about hyperthermia, but the rest that could know something have a very, very bad impression or knowledge about hyperthermia, because all of us has a patient that say, okay, I have gone to that center and they told me that they could cure me without the conventional treatment. And this is very, very, very bad for the image of hyperthermia. And I have said in my presentation that I really have seen a very good effect of symptomatic effect almost all the patients, because they produce an anti-inflammatory effect, a relaxation, and most of the patients during my sessions get asleep. They sleep because they feel relaxed and they feel better. And that was the reason why in some alternative centers have used the hyperthermia as a unique treatment for some oncological patients. So we have a problem of nobody knows about the hyperthermia in the scientific community, but the few people that know something have a bad impression. So we have changed this image of hyperthermia. I think we are changing this because this is not for me, but because we have tried from SEOR to give more information and trying to improve the technique in different centers. Now we have 9 centers with hyperthermia inside the oncology department. This is incredible 5 years ago. And I think that we are going to improve in the following years.
Thank you so much.
So if you want to have lunch, I think I have to call time, but I'll just make a comment from online. A suggestion has come from the online in terms of organizing an international school of hyperthermia, where to teach to the medics.
First, we have to organize a national school.
So where do you start? You start from the chicken or from the egg? But this is thrown to the space, because this is the right environment where to discuss. We have regulators, we have key enabler, we have the academics, we have the clinical people, and that's a very valuable discussion that should be actually stimulated around lunchtime. If you don't fall asleep, otherwise, he has a session of hyperthermia for everybody.
No, but this is a very good question, because in the meeting in Las Palmas at the end of June, we are going to propose to be more to grow and to make a national society that could incorporate all the professionals that are doing hyperthermia. I have to say, I feel like I feel the things are like that. The hyperthermia is very close to radiation oncology, but it's not a technique of the specialty. So we have to involve the medical oncologists, the physics, the biologists, the research, and trying to put all the actors together and try to propose to have an international congress in Spain in 3-4 years of ESHO and give visibility.
There.
One book was listed. That's why I take the patients on board.
Yeah, of course.
Because if you forget them all,
Absolutely.
there's no effect.
Absolutely.
We couldn't bring them all here. Otherwise, it would have been. That's another type. This is public engagement and public patient engagement, which is very important. But I agree, but that's when you come as an established. Where today we discussed the most fundamental aspect.
Correct.
Of
patients are not able to clarify the basic scientific process. This is often not their task, but they can, for example, say if they have this kind of skin effects, how much they have to be affected in the therapy. Was it comparables, for example, to chemotherapy or not? This is something we cannot say. This is what they have to say. And if they take the risk at the end, they take the risk, not you and me.
Oh, absolutely.
Yeah,
Absolutely.
That's why we have to include them.
Yeah.
It's a very good point. Okay, we need to call the round table. I'd like to thank you all for taking part and ask more questions during lunchtime. So you have identified the people that ask the question and the one that can answer. So don't hesitate to go there. Thank you.
Good afternoon, everyone. Welcome back to the afternoon session of this very nice workshop that we're having today. We're having 2 talks this afternoon, one by Luke and one by Julia, and then we're going to have a round table. But to kick off the session, we will have a talk on entitled European Regulation of Medical Devices and In Vitro Diagnostics Rare Diseases Perspective by Luke Van Hoof of Maraca International. Thank you. Over to you, Luke.
Thank you, Peter. So this morning, we talked about preclinical and the first steps into clinical feasibility study, so which is actually prior to the pivotal clinical investigation. So now, the afternoon, we'll talk about what Safe-in-Medtech offers to their clients when, like the RCL test case, are building their technical documentation and their quality management system to see whether that package of technical documentation quality management system is sufficient to move then to the notified body, so that they are not surprised that the notified body are saying, nah, that's not what we need. This is where work group 7 is coming in to work with the clients to do the gap assessment of the technical documentation and the quality management system and help them close the gaps. This is a very broad topic I'm talking about. So it's only the tip of the iceberg that I'm talking about, but it's a very critical element. It's black and white. You have the data or you don't have the data. It's that simple. Competent authority is black and white thinking. There is no gray thinking there. So I need to, with that topic, I need to talk about the different types of devices: orphan device, humanitarian use device, compassionate use device, custom-made device. Then I'll talk about what is rare disease versus rare cancer for pancreatic cancer and for prostate cancer. Then we'll move into this broad topic of the regulatory roadmap to bring a device to the European market. That on itself is worth a day of presentation. It's going to be a few minutes. We'll then look to what is clinical evidence, what is the clinical evaluation, which is a regulatory term in the regulation, and that differs from a clinical investigation, and the confusion around it. That brings us to the conformity assessment, and that's where the notified body comes in. Whether you have all the clinical evidence for your device to be authorized to put the device on the European market. And we'll talk then about what are the future steps for the no-canter study and the RCL system, the generator and the RCL agent. So let's look first to the type of devices. An orphan device is not existing in the European regulation. It is not introduced in Europe in the MDR and the IVDR. It was introduced in the medicinal legislation in 2002. So orphan devices are medical devices intended for treatment of very rare, life-threatening or chronically debilitating conditions, but in Europe, not existing. Humanitarian use device, HUD, that's US terminology, US regulation. It's not existing under the European regulation. What about compassionate use device? Not in the European regulation. There are two elements in the European regulation to bring your device to the market in Europe. That is either a custom-made device, and that is mentioned 37 times in the MDR. It's not mentioned in the IVDR. The IVDR stands for in vitro diagnostic device regulation. MDR is the medical device regulation. And it's very restrictive. What is not on the slide shown here is the derogation pathway. So in both regulations, the MDR and the IVDR, there is an allowance under certain conditions that you have a derogation and that you, in a particular country, for that country only, you can get authorization by the competent authority to put that particular device on the market. Okay, second element that we discuss, rare disease versus rare cancer. For rare diseases, prevalence is used. So prevalence less than 50 cases per 100,000 defines a rare disease, and prevalence looks to the proportion of people that have, for example, cancer or a condition in a particular time period, all the cases, new and existing cases. So that's all the cases. The problem with cancer is that from cancer, people are dying. So its prevalence is not a good indicator for specifying rare cancer frequencies. Incidence is a much better indicator, and incidence looks to the proportion of people that develop cancer over a particular time period. So these are the new cases, annually, so many new cases. In Europe, there was a concerted effort supported by the European Commission to define what is a rare cancer list, and that is captured in the rare care net documentation. Any threshold is artificial, and you need to work with those thresholds with some flexibility. The clinicians were putting the cancer cutoff at 6 cases per 100,000 per year. And that's a consensus based on the clinicians looking to those rare cancer lists. 24% of all new cancers are rare. So now we'll zoom into pancreatic cancer and later to prostate cancer. And we'll go through this exercise. The 4 cases that were presented today for the no cancer study were adenocarcinomas. You have also other subtypes, the squamous carcinoma and the acidocellular carcinoma. Those 2 are rare. Adenocarcinoma is not considered a rare cancer. For pancreatic cancer, this is here what is in that rare cancer list. And adenocarcinoma is not considered a rare cancer. It has an incidence of 7.96, which is above the 6, whereas these others are other pancreatic cancers, and they have very low incidence, and so they are rare. The same for prostate cancer, with the same incidence of less than 6. You come to the similar conclusion. Adenocarcinoma of the prostate, 49% of 49 per 100,000, so they are not rare, whereas squamous cell carcinoma, transitional cell carcinoma, and a few others are considered rare. Okay, having said this now about rare diseases, rare cancers, now we are moving into the regulation. There are 2 two regulations that are applicable. The medical device regulation, 2017-745, active as of 26/05/2021, and the in vitro diagnostic regulation 2017-746. It's the sibling regulation for IVDs, and that's active as of 26/5/2022. It always comes down to you need to establish for your device safety and the performance of the device. That are the two elements that you need to have documented, safety and performance. And that basically follows a regulatory roadmap with discrete steps. It starts with the intended purpose of your device. Many of the clients, when you ask the intended purpose, that intended purpose is not well defined, and there is work with the client to come to a well-defined intended purpose. Then you classify the device, so that's the regulatory strategy documentation, and then you need to establish the clinical evidence for that device, and that includes three pillars. Scientific validity, the systematic literature review. This is not just a literature review, it's a very structured, systematic literature review that ties in the IVD case, the biomarker to the clinical condition. Then the analytical performance characteristics. And the third pillar is the clinical evidence of the clinical investigation data. And those three pillars together are part of the clinical evaluation report. So clinical evaluation for competent authority, for notified bodies, and if you are in this regulatory space, has a very specific meaning and is different from the clinical investigation, which is the study. Whereas the ISA guidance on medical device studies is using the term clinical evaluation as a clinical study term. So there's confusion in terminology. When you have sufficient quantity and sufficient quality for your device of that clinical evidence, and what is sufficient quantity and quality, that is not in the regulation, but there are MDCG guidance documents published around that, 2020-06, with a hierarchy on what is clinical evidence and what's the value of that clinical evidence for your device. So that's the MDCG document to look at. It should be clearer for yourself what sufficient clinical evidence is for your device, and that needs to be compared to the state of the art. So it's not just the data of your device, it's always in the context of a comparison to the current state of the art. So you need to have documented also the field. That's captured in a clinical evaluation report for a medical device or a performance evaluation report for an in vitro diagnostic device. And if you have this all well organized, systematically organized with table of contents of your technical documentation, table of contents of your quality management system, to the point of this is the name, this is the version. At that time, it was signed off. If you don't have that information, guys, you are not ready to go to the notified body. You have work to do. And guess what? Everyone who came to us was not ready. There were gaps that we needed to close. The notified body obviously is not an advisor. So what you put on their table, that's a final review. You pass or you fail. So you need to have someone who helps you to basically be ready with your technical documentation, your quality management system, to put it in front of the notified body and the competent authority. That's a service that SafeMedTech offers to their clients. So then the notified body will do the competent assessment, and Julia will talk about that in greater detail. That leads then to your CE mark that you can put on your device, and you can put that into the UDEMET database, and you're off to go. So the first thing to do on that regulatory roadmap, by the way, for SafeMedTech and their clients, that regulatory roadmap is provided as a report, so it's clear. This is the same for conventional medical devices and IVDs as for nanotechnology devices, with some distinction that nanotechnology materials are mentioned in the MDR regulation, not in the IVDR regulation, and there are specific classification elements around nanotechnology-based devices. But the first thing that you need to do is define your intended purpose. And it's the two regulations are very prescriptive. They tell you what needs to be in that intended use. And typically it's not there. Not all the information is there. Then there is work to put that in place. Without an intended use, you don't have a medical device, you don't have an IVD, you have a research device, not a medical device or an IVD. Then you go to the classification, as I mentioned, and you need to establish which GSPR requirements are applicable to your device, your general safety and performance characteristics. You need to establish your risk management system. You need to specify which harmonized standards you are using and which common specifications are you using. And there's a lot of terminology here, but it's very specific terminology. Common specifications can only be published by the European Commission. Yeah, so I'll stop there with that explanation. The devices are classified by risk. For medical devices, it's low risk is class 1, and then increasing risk is up to class 3. IVDs, it's class A up to class D. COVID tests, that COVID test that you used to see whether you were infected with COVID at home, that's a class D device, okay? The European regulations until now did not come up with an emergency use authorization like in the US or by the WHO, but they came up with a very inventive approach to control the quality of those COVID tests. In order to get your COVID certificate, that could only be done with validated tests that were tested by European reference laboratories like the Paul Ehrlich Institute. And that was building the list of validated tests for COVID. This was due to the pandemic, very fast European regulation that came in place for that specific situation. And it actually is better than the American and the WHO emergency use authorization. It gives a higher level of quality. Safety performance requirements, I'm not gonna stop to this, only maybe there are specific requirements around nanotechnology, nanomaterials in the NDR regulation, which you need to take into consideration. What you need to do is have a risk management system, do that clinical evaluation. This is the regulatory term. This is not a clinical investigation, it's the clinical evaluation. Talk about that a bit later in greater detail. Build your technical documentation, do a conformity assessment, have a unique device identifier, have a quality management system that is ISO 13485 2016-A21 11 2021 applicable. Why that dash? Because in that ISO standard with that dash, you have alignment of the standard with the NDR regulation and with the IVDR regulation, and set up a post-market surveillance program and a vigilance program. So that are the elements that you need to have, and they need to work before you go to the notified body. Clinical evaluation, Article 61. It's a set of clinical evidence rules pertaining to each device, and it's a continuous assessment. Annually, you need to do an assessment of the clinical evaluation. So it's a life cycle approach. And the question is, do you still have sufficient clinical evidence? I talked about the clarification in the NDCG. Either you have sufficient clinical evidence, that's your decision. Okay, your CE mark is applicable, or you don't have sufficient clinical evidence. There could be gaps. Then for the gap, you need to do one of these. Either do a clinical investigation. That's the full-blown Monty, the big thing. Or you could use real-world data from the literature through post-market surveillance or as a post-market clinical follow-up study. There are differences between what can be done with real-world data versus the clinical investigation. With real-world data, you are looking to a larger group of patients. You are using less experienced users. It are not those super duper Waldebron experts that we heard about here. With real world data, it will be less experienced users that are involved. And this real world data will help with the identification of rare severe adverse events and with long-term safety and performance and effectiveness information. That's where real world data will help. This is built into the European regulation now, and it's clarified in those two MDCG documents I talked about at 2020-06, with that hierarchy of what is sufficient clinical evidence, where it is stimulated to use real-world data, for example, of registries for getting market access of legacy devices. Not if it's a new device, then that would not apply. But for legacy devices with well-established technology that can be considered. There is further clarification in 2020-07 MDCG around the post-market clinical follow-up plan that explains what real-world data can be. Where are you applying it? To support pre-market clinical evaluations as a supplement, to be used as an external control of a clinical investigation, for example, to construct target values for some patient populations, to expand the intended purpose, or to put new contraindications in the instructions for use, long-term safety and effectiveness data for high-risk devices. And for rare diseases, you want to have a whole lifetime clinical evidence data set for such a device. It's also used for post-market surveillance studies and post-market follow-up studies. And this could lead to a conditional approval, but not for new technology. That would be applicable to legacy device if the technology is well established. Of course, the quality of that real-world data needs to be protected from a representation perspective, completeness, accuracy, consistency, authenticity, and reliability perspective. Clinical investigation now. Under the medical device regulations, you can do a clinical investigation. So now we talked about real-world data where you can apply that. If you don't have real-world data, as discussed before, you need to do a clinical investigation. For most, if not all, new devices, you will have to do a clinical investigation. There are 3 articles that talks about this. Article 62 is for a new device where you need to establish the conformity for a conformity assessment. Article 74-1 is where the device is on the market and it has a CE mark, but you have that device used for another intended purpose. So that's that article. And then there are other clinical investigations that are not conformity assessment supportive, but that are addressing other topics that is covered under Article 82, and that is under national law. So for a Article 62, clinical investigation as a preclinical study for conformity assessment, there is no CE mark. You need to establish the safety and the performance and the benefit-risk ratio of that device. You need to follow good clinical practices, ISO 14155, and you need to have authorization of the competent authority and of the ethical committees. For a post-market clinical follow-up, if it's for a conformity assessment, so outside the intended purpose, then again, you need to follow good clinical practices, ISO 14155, but a competent authority notification is sufficient. It's not an authorization. And of course, you need to have an ethical committee authorization. Then for Article 82, you are under national law. Clinical investigations overall have an application process. In the future, it's going to be in the European UDEMET database. Right now, it's in the local databases. Ireland, Germany, Spain, and so on. It's a headache right now because They are following the same regulation. They are following the same European template, and they are still coming up with differences in what needs to go into that local database. So hopefully, when it goes into the UDAMED database, it's the same for everyone, hopefully. You need to have that quality management system in place. You need to have your people trained. They need to be compliant in the execution. You need to have your safety reporting structure in place, and you need to show transparency in what you are doing. So that are the common elements. That means also that you need to have your health and safety information on your patients, the circumstances of your system, and you need to protect the rights, safety, dignity, and well-being of your subjects. And the data that are generated need to be scientifically valid, reliable, and robust. There are additional requirements for some studies. If it's a surgically invasive sampling procedure like biopsy taking of the tumor, additional requirements. Interventional studies, additional requirements. Companion diagnostic IVDs, additional requirements, and so on. And you need to have, as we mentioned right now, prior authorization of the member state, prior authorization of the ethical committee. In some countries, centralized ethical committee, in others, localized ethical committee. You need to manage the risks and the benefits of the subject. You need to have informed consent and make sure that there is no undue influence. And ethic committees and competent authorities are sticklers about this. Making sure undue influence is critical. You need to have, obviously, your analytical performance data, your scientific validity data, and your site needs to be, and the people involved need to be qualified. This all comes down to you're building your clinical evidence for your devices. There is scientific literature data on your device and similar devices. You need to consider alternative treatment options and collect all that data. There are a few exceptions, but not applicable to the majority of us. Then that brings us to the notified body. Conformity assessment. Depending on the type of device, if it's a class 3 device, every device goes through a technical review and a review of the quality management system. It's a class 2B device, then there is a representative set of devices that needs to be technically reviewed. The quality system is also audited. It's a 2A, then it's another set of representative devices that will be assessed for a technical file review. Quality management system will be involved, and only if you have a class 1 device, no notified body will be involved, except if it's a sterile or a measurement function device. You need to have a quality management system, but it needs not to be certified by the notified body. So this brings me to the end of the overview, the questions for the no-counter study. So the way that the device was presented to the regulator is the generator device is a 2B device because Rule 9, it provides thermal energy exchange, and there is a potential hazardous way in there. And RCL, nanoparticle iron agent, is per Rule 19 on nanomaterial with a medium potential internal exposure and therefore a class 3 device. So that's how it was presented to the regulator. It's in pancreatic cancer. It's the adenocarcinoma, so it's not a rare cancer. It's a first in human feasibility study. And the first 4 patients were not having serious adverse events related to the procedure. So the question is now, what is next for this system? Is it a clinical investigation on safety and effectiveness per Article 61? Or could you consider a post-market clinical follow-up approach on safety and effectiveness per Article 74? And I'm sure that the notified body is going to have a very clear opinion about that. I'm just asking the question. And last but not least, if you look to the other application being the prostate cancer, there is already FDA guidance on ultrasonic prostatic ablation submissions to the FDA. In 2020, FDA specified what are the requirements, inclusion, exclusion, and what you need to measure and so on. Very valuable guidance. Could be applicable also to pancreatic cancer. So I would look to that in great detail in preparing what is the next study for the RCL generator and the RCL agent. And with this, I come to the conclusion. I don't know how is the time right now. Huh?
5 minutes.
Okay, good. Finished in time, good. Yeah, so. So if you have burning questions, you can ask it at the round table, I presume.
I was going to say, we have a little bit of time, so if you had a question straight away. I think if you go to this, oh no, you can't really go back a slide.
Yeah, I can.
This thing about pancreatic cancer not being a rare cancer, we are looking with the no cancer study at locally advanced non-resectable. Does that clinically, that surgical classification allow us to subdivide, because we're not far away from being that rare disease classification with adenocarcinoma, pancreatic cancer.
Right, that's a very good question.
Can you make a classification on the basis of
well,
that?
so your first cut in that classification of rare cancer is going to be that incidence of 6, huh?
Yeah.
Which is going to be, it's an arbitrary, it's an arbitrary threshold set by the clinicians. You, from a clinical perspective, the clinicians could come to a conclusion that you could further look in subdivide. Why am I saying this? If you look to colon cancer is not a rare disease, but if you look to the colon cancers that are KRAS positive, suddenly that KRAS positive colon cancer, if that is your indication, that becomes a rare disease.
Okay. All right.
So you can think about further subclassifying, and there is evidence that it is done before.
And it's only in the States that it makes a difference in terms of the regulatory pathway.
That is a big difference. Yeah. Yes, big difference.
Right. Okay.
Yes. Whereas in Europe, whether it's a rare disease or a common disease or a nanotechnology-based disease, all the same.
Okay, perfect. Perfect. Thank you very much. Thank you very much. Yeah. Our next speaker is Julia Caro Barry. Yes. Are you mic'd up or not? No. Do you want to? Oh, okay. Oh, fine. So we are really privileged. I think it's a phenomenal thing for us to have the privilege of having Julia here today to give us the perspective from the notified bodies. You know, normally I tend to think of the notified body as being somehow behind a wall, somewhere, something a bit distant, but here you are, and we're very grateful to see you here. Thank you.
Thank you, Luke. So I have the honor to hold the last session, the last talk, and I'm going to talk about legislation. So I try to make it as light as possible, and I hope you still, bear with me until I finish. Don't leave the room, please. So I'm Julia. I am the head of area of the CNCPS, that stands for Centro Nacional de Certificación de Productos Sanitarios. It's very likely that you don't know the Centro Nacional because we just started working under this name from July last year, but we've been notified body since 1995, but working inside the organization of the National Medicine Agency here in Spain. I always like to start with some common misunderstandings related on how medical devices are put in the market. But after Luke's presentations, I hope everything is clear now. So some aspects I will go again on them, but others I will share my point of view with you. So some people, when we first know about this sector of medical devices, they tend to think that medical devices are regulated in the same way as the vacuum cleaners because they are regulated with the CE mark. So maybe they follow the same standards and nothing else. And because we, the notified bodies, we are selected and paid by manufacturers, usually people tend to think that we are not able to take independent and scientifically decisions. And we just put the medical devices on the market because we are being paid. So on my talk, I will address these topics to maybe make you think about this sector. So first, I will start by introducing you to the how CE mark, what is the relationship between the CE mark and the medical devices. And I like always to start with this slide, and because people usually tend to think that people is always saved by medicines, is drugs which are used in the main step to save people's life. But if we look around, when we go to a hospital, we can see that we are surrounded mostly by medical devices, not only by medicinal products. And as you see, they are really different in nature. They work on different ways. So the main point here is that medicines and medical devices are the only products that can be put on the market with that can claim a medicinal purpose. Okay, and they both aim to improve people's life. And the way what differentiates them is the way in which they achieve their purpose and the mechanism of action. So medicines, they are by pharmacological, metabolical, and immunological means. Usually there is a receptor binding or an enzymatic reaction in the body, whilst medical devices works by mechanical and physical means, barrier, as well, lubricating, hydrating, modifying the pH are also considered to be a medical device mechanism of action. So in this topic here about the the thermotherapy, is because we are using the magnetism in the iron particles, and this is the way we are using a particle and not a chemical substance. And for that reason, we are talking now about medical devices and not drugs. Is because their mechanism, the way they act by hitting the tumor. And because it's a physical way of act, it's not a drug, it's regulated via medical device. So for drugs, they are authorized through the national and European systems. So we want to commercialize a drug, we just address to our national authority, or maybe we can go to EMA that are responsible for the drug authorization, but then we need to see that this is a figure from 2015. I haven't found anything more undated than this, because I don't think you can quantify how many different types of medical devices we have in the market now. 7 years ago, we were talking about 500,000 different types of medical devices, comparing to 20,000 medicinal products. So given the large number of medical devices and the difference, the huge difference between them, this regulatory model, this interventionist model, doesn't seem really feasible to authorize a medical device. So here I want to show how medical device legislation were historically was foreseen. So before the 90s, every member state had his own regulation of medical devices. Here in Spain, we have several royal decrees, and they used to be like vertical legislations, one for sterile products, another one for contact lens solution. So they were like really particular, and if a manufacturer wanted to market the product in another country, they needed to comply with the national regulation. So then all this European market started, and they thought that the CE mark model could benefit this kind of sector. So the directive started, and the medical devices were regulated through 3 directives, one for medical devices, the general ones, another one for in vitro medical devices, and then we had one directive especially focused on active implantable. Then some modifications arrived related to encephalopathies, some prostheses were reclassified, and then they compiled all these modifications. But this kind of regulation didn't seem enough, because on I don't know if you remember, but on 2012, the scandal of the mammary implants arrived, and there were a lot of things on this legislation that weren't working properly. The manufacturer didn't do things right. The notified body couldn't be there on time. The market surveillance that is done by the competent authority wasn't working properly. So there were a lot of things that weren't working properly. So the new regulations that Lux already talked about us came, and they are called the MDR, the medical device regulations, and the IVDR, one for in vitro. So the active implantable devices are now included here in the medical device regulation. And this legislation is prepared when this was published in 2017. Regulators were foreseeing that all devices that were certified under this scheme by 2024, all the devices have transitioned by this year. But then on October 2022, only 9% of certificates had a transition to MDR. So the rest of the certificates were still issued under the old scheme. And the thing is, after this year, the certificates are no longer valid. So there were a lot of discussions with the European Commission, because the risk of shortage was really evident here with the situation. And on the 20th of March this year, another regulation was published, and now the validity of the certificate has been postponed. So they hope that this year all the certificates can comply with the new regulation, because we see we are not arriving to this year here. So what is this thing about the CE mark, and why is this model is suitable for medical devices? So we see in the market that we have like different kind of products, from a model where the high-risk products are regulated with a greater level of intervention by the competent authorities, and we go to a lower interventionist model. For example, when cosmetics, like they only need to claim safety and quality, they don't really need to claim any kind of efficacy. So if you just, or maybe shoes, conventional items, they are not really regulated. On the other side, we have all these medicines that manufacturers need to apply every time they want to change things. And in the between, we have these kind of products, medical devices, toys, lift, construction products, that they are like risky, but because they are produced in huge quantities, they are like really different. And as I said before, an interventionist model didn't seem right to authorize them. So these are all regulated under the CE mark scheme. And this means that the competent authorities delegate the certification to organizations called notified bodies. And then in turn, we are supervised by the competent authorities. They come to see us once a year. And by sampling, they choose the item they want to see, usually high-risk medical devices. And then after everything is done, notified bodies, we issue a certificate that is recognized throughout the European Union. It's like a kind of passport. So the manufacturer doesn't have to reapply to another national authority for the CE mark. All these regulations are called the new approach. The one for toys, for medical devices, they all belong to the same scheme. And the common key aspects on those regulations are that the manufacturers can choose between different conformity assessment. All the content of the legislation is really restricted to essential requirements that Luke's already talked about before, and that products must meet when they are put in the market. And this legislation requires a surveillance by a notified body. And among these new approach legislation, we find the medical device legislations that includes additional sanitary requirements. For example, we need clinical evidence that supports the performance of the device. We have an European vigilance system. When an incident happens with a medical device, we need to notify it. Everybody knows what happened with the device. And then there is a public information database that is called EUDAMED that you can access, and this didn't exist with the directive, and all this sanitary and health requirement has been reinforced here with the new regulation. There was a lack of information about medical devices when you wanted to check if a medical device is commercialized or which classification was it. It was like really hard to find it, and now with this database called EUDAMED, you can search by the classification, the type of device, and you can get information about where in Europe is commercialized and at least a minimum set of data. So what is this? What are these general requirements that are required to the medical device to be authorized? So if we turn to Annex 1 of the regulation, we see 23 requirements that the medical device need to meet when they are put in the market. But the thing is, they are written in really general. So the intention is that they remain valid over time and do not become obsolete with technical progress. And all the specific criteria are set on the European harmonized standards that are really much easier to update than a legal test. So let's see an example. For example, devices that have a diagnostic or measuring function, for example, a syringe or like a cup that comes with the cup syrup, for example. The requirement is that the diagnostic devices shall be designed and manufactured in such a way that to provide sufficient accuracy, precision, stability for the intended purpose, blah, blah, blah. So it doesn't really say which criteria they need to meet. So for that reason, we need to turn to the ISO standards. For syringe, we have the ISO standard 7886 that contains a specific set of criteria that all the items need to meet. So we are in the notified body, we just check the technical file of the manufacturer that all these tests has been done, the data space, the accuracy, the precision. So we have We don't really have a standard for every product, but at least the intention is to have one. So as Luke already told us, medical devices are divided in 4 classifications. We go from class 1, that are really like from low risk devices. Risk in medical devices is understood as the harm they would do to a patient if they fail. So for example, devices that belong to this class, they are not really invasive, usually like they are used in health skin that is not damaged. Class 2A devices, for example, a contact lens or a needle belong to this class. Class 2B, all the intrauterine devices, and then class 3, so more of the implants fall in this category. And for this medical device, they require a certificate issued by the notified body, and only certain class of class 1 devices need a notified body intervention. The one that come with a measuring function, they require it, and the one that are commercialized being sterile, also they require our intervention. So to know how to classify the product, there is an annex on the MDR, and as well it contains 23 rules that help us classify the device. And we have a specific rule for nanomaterial, and according to the potential risk of the internal exposure, we find that they could be class 3, 2B, or 2A. And then in this guidance, it helps us a lot, like to find examples for products falling into every one of this category. And we see that in this rule, in class 3, we see how supramagnetic iron oxide nanoparticles, they fall until class 3, with all intravascular catheters, bone fillers. And if we turn to class 2A, we can see, for example, dead and feeding materials. So we just see how the MDR, this regulation, classify the products according to the risk. So now once we know what a medical device is and how they are classified, I will show you how a notified body works and how we are structured. So notified body, we can be public or private organizations designated by our competent authority, that in Spain is the Ministry of Health, but in other countries it could be the Ministry of Economy or the Ministry of Industry that designates the appropriate notified bodies that needs to perform the conformity assessment of the product. In Europe, the situation by June 2023, I checked this yesterday, is this one. Not all the countries has its own notified body. It's a decision that involves a lot of things. You need to have like enough competent people to work for your notified body. You need to have an industry, because if you don't have any clients, then your viability at long term is not guaranteed. So for example, Portugal, they used to have 4 notified bodies. Now they have none and no intention to have another one. We see countries that they don't have any, but on the opposite, Italy and Germany here are the real kings because they have 10 notified bodies each. The UK, they used to have 6 or 7, but after Brexit, some of them, they closed. Some others, they just moved to the Netherlands. So this is the situation now. And every notified body has a unique identification number of 4 digits. We have a website where all these notified bodies are listed. And you can check the scope because not all notified bodies can certify all of the products. So we have a reduced scope, for example. And most of notified bodies are private organizations, BSI, TUBES, Eurofins, EMQ, they are SGS, so they are usually the most known ones. And me being part of the CNCPS, I have to say we are one of the few that we are 100% public. We belong to the Spanish Medicine Agency. We are a kind of a subdirectorate. And it's not a model that is really common. I think we are only 3 notified bodies that are 100% public. Another one is in Italy, and another one is in Greece. They are still in the process of getting the designation, but the rest of the notified bodies are private organizations. But it's a model that is foreseen in the regulation and is valid, and is the way it is in Spain. So as I said, every notified body has an identification number of 4 digits. Our number is 0318. And if you see a medical device that bear these digits under the CE mark, is because it has been certified by us. And now briefly, I will go through the CE mark certification process and into the highlights. So first of all, when a manufacturer has developed a product, they need to have implemented a quality system in their company. Usually the standard that is recognized throughout all the in Europe and abroad is an international standard. It's called ISO 13485 and is voluntary. There's no need to have this implemented. In pharma, they need to have, is mandatory to manufacture under the GMP scheme, but in medical device, you need to have a quality system implemented, but you don't really need to get it certified by another organization. So this standard is similar to ISO 9001. I don't know if you knew already this standard, but in hospital still they still require manufacturers to comply with this standard, because I don't think that they know that this is more specific for medical devices, but they still ask for this standard for the manufacturers, but this is way more, by far more specific for medical devices manufacturers. The thing is here, in medical device sector, a manufacturer is the company that put in the market the medical device under its name. So a company can be a manufacturer and then have all the fabricating process subcontracted. So you don't really need to have a proper facility. So you can have just a contract with another company and can produce the medical device for you. But then if you're a manufacturer, you need to be responsible for putting into the market. And then having this ISO being certified is voluntary. And we as a notified body, we also issue these kind of certificates. And we work under the ENAC accreditation scheme. So apart from having a quality system, a manufacturer that wants to commercialize and that wants the CE mark of the product needs to gather a set of data before applying for the CE mark. And all of this data is needed because we need something that proves the device works as expected for the intended purpose. And usually this data is gathered through engineering, laboratory, simulated and animal tests, evaluation of published literature. So depending on the requirements we've seen before, the test needs to start, and usually they will cover the biocompatibility. And we have this ISO standard that is, sorry, this is a 1, it's not a 2, but it's the ISO 10993/22 that is specific for performing the biological evaluation of nanomaterials. Then we as a notified body, we will ask for a physical, chemical and microbiological characterization of the product. If there is, if the device works by electrical or batteries or electrical mode of action, then we need to have this checked. Also, there is a set of standards that tells you how to perform all these tests. Usually you need to take the medical device to a specific laboratory to make them perform this test for you. If there is a software incorporated in the device, then we will ask for the validation of that software, the stability, including the shelf life and performance and safety. For example, how the alarms work, how are they settled, can anyone manipulate it? And now with all these developments in technology, we will ask for the cybersecurity. All this artificial intelligence as well is like really hard for us to to assess if someone has taken the proper measures on their device. And then, well, the key point now with the regulation is the clinical data that needs to come with the device for obtaining the CE mark. And what the MDR tells us is the confirmation of the requirements need to be based on clinical data that provides sufficient clinical evidence. So here, two questions arise. One is, what is considered clinical data? And the MDR things tell us that clinical data can come from different places. First, what all we want is a clinical investigation, okay, with the device. With the device, if you don't have that, or you can pay that, or you don't have access to this kind of clinical investigation with your own device, then maybe a clinical investigation of the device, or with a device that is equivalent to the device in question, can be accepted as well. Then we accept reports of published in peer-reviewed scientific literature or other clinical experience. This is also something we can accept. And then clinically relevant information coming from post-market surveillance, in particular post-market clinical follow-up. But to have this kind of data, you need to have your product already in the market, but it's difficult to have a post-market evaluation if you just have developed your device. And then the other question is, what is considered sufficient? Okay, I have all this clinical data for my device, but are you going to accept this? Are you going to give me the CE mark with what I have? So this MDCG, the 2020/6, that is this kind of guidance. This guidance is developed by the European Commission. Defines sufficient clinical evidence as the present result of the qualified assessment which has reached the conclusion that the device is safe and achieves the intended benefits. Okay. So let's look further into this. So, because it's up to the manufacturer to decide if they have the sufficient clinical data or not, at least this guidance show us and tell us what is a hierarchy of what is considered sufficient clinical evidence. And we see now clinical investigation, that is the way we call clinical trials in medical device, is on the top of the evidence list. Then clinical registries, peer-reviewed scientific literature, equivalence data with an equivalent device, state of the art, vigilance, surveys, case reports. So we see a case reports is really down on the scale. So there are states that in case of class 3 unimplantable devices, clinical investigation shall be performed. Okay, so we don't accept anything that is not this. But some exemptions are allowed. For example, for legacy devices, legacy means that the device is already on the market under the MDD, under the directive scheme. So because they have been on the market, we are not going to ask you again to perform a clinical investigation and to put, more patients in risk. So we can accept a low level of evidence. So if you do, a changement, a modification in your device, we are not going to ask you for another clinical investigation. Okay, that's fine. If you can demonstrate that your device is the same device as the other manufacturer that has sufficient clinical data, then we're going to ask you to show that equivalence. And then we ask you for a contract with the other manufacturer, because we want to see the information of the other manufacturer. And then as well, if your device falls into this category, the well-established technology, then non-clinical investigations are required for the CE mark. This well-established technologies is a positive list. So if you don't fall into that positive list, then you are a well-established technology. Here we are talking about implantable devices like sutures, dental crowns. They are so a low level of evidence is required. So for this, for implantable or class 3 legacy devices, okay, you don't need to perform another clinical investigation only if you have sufficient clinical data minimal at level 4 of evidence. That means only clinical investigation with some flaws, with some bias can be accepted, and information from clinical registries, from real world evidence, is accepted for legacy devices. And once you have your quality system implemented, once you have all your preclinical and stability and software validation, and once you have all your sufficient clinical data, then you think about, okay, asking for the CE mark, and you start to compile all that information in a structured index that for the first time comes into the medical device regulation, because before every manufacturer presented the documentation the way it was. The index was, usually it was something agreed between the manufacturer and the notified body, but now in the MDR for the first time provides a structure of information that has to come with the dossier, with the product, starting by the description of the product, all the labeling, all the design and manufacturing information, the general safety requirements, the benefits risk analysis, and then this product verification validation. This is higher because this is where all the magic happens, where all the relevant information is compiled. So all the certification here, I'm missing one step. That the first step is to find a notified body, because as I said before, not all notified bodies can assess everything. You need to check in advance the list if the notified body that you prefer, or that is in your country, or that has sufficient availability, has the scope of your product. And once you have found your notified body, you just contact them, and the application starts. Then, if everything is accepted, the assessment of the technical documentation starts. And we give the manufacturer the possibility to, because some non-conformities may arise, usually always we arise some non-conformities, and we give the manufacturer the possibility to make amendments to the documentations, to make new tests. And depending on the medical device, some external consultation is required. For example, we can find medical devices that incorporate some medicinal substance, and they are certified under the medical device regulation. For example, that contains simvastatin. So the main action is because of the stent, but the ancillary action is because of the simvastatin. So we need to contact the medicinal authorities, and they will review the simvastatin part, the medicine part, and then the report comes back to us. Or if we find a medical device that is really specific, then we find a clinical expert, and we just ask them to do a report on a specific, for example, for the clinical evaluation. We just give the clinical evaluation to an expert, because for some devices, they are so new that we don't have experience in evaluating them. The only thing is, for us, it's really hard to find a clinical expert, because if the medical device is so specialized and is so new, usually the POPE or the external expert that knows the most has intervened in the process of developing and there is a conflict of interest. So for us, it's really hard to find the proper expert, because when we ask them like to evaluate the product, then they ask, no, because it hasn't been me, but maybe my team has participated in develop, so blah, blah. Well. Then when the technical documentation is reviewed and the product is more or less ready, then we go to the facilities and we perform a quality audit. We just review, we see all the machinery, all the equipment. We confirm that if you have declared that you are using this particular raw material, we'll ask for the invoice. We want to check all the registries, that everything is well performed. And if everything is, we also arise non-conformity here a lot. And then if everything is solved, it has been closed, all the non-conformities, then we do a final review and we take the certification decision. CE mark certificates last for 5 years. After that period, the manufacturer needs to apply again, and we do a recertification. And in certain cases, maybe the time can be reduced if we have doubts, but just the common is to give 5 years validity to the CE mark. And you may think, okay, I'm done, I have my CE mark, and now I can market my product, but unfortunately, the process doesn't stop here. But the manufacturers are subject to annual on-site audits by notified bodies, regardless of the classification. Even for the class 1 measuring function devices, we need to be there every year to check everything is well manufactured. For example, we check that the item is being manufactured under the same approved conditions, with the same raw materials, the same facilities, the same in-house control. Also, any modification of the device is subject to a notification to the notified body, and then we need to assess is another evaluation needs to start, or if we just approve the modification. And then the notified body will review the post-market information gathered by the manufacturer through the sales, incidents, updated clinical data from studies, literature, and for Class C devices. This is called the PSUR, the periodic resume of safety and performance. Is a report that they need to send us annually, and we need to review and check that everything is okay and is performing well with the device. And well, this is my contact if you want to reach me. And as a final conclusion, I told Álvaro Somoza before, I think we got to the same conclusion that during the development phase, during the certification process, and during all this post-market activity, the involvement of the health professional is key, because sometimes it's frustrating when you receive a dossier of a medical device and the clinical investigation has been performed with another intended purpose. This happens a lot. Or the device that was tested in humans differs from the one that is finally approved by the manufacturer. So they need to redo again all the clinical investigation. And I'm sure if the clinical advice is involved at the beginning of the development of the device, then we will have, medical devices more accessible, in a quickly manner, and well, at least is all we want.
Thank you so much, Julia. So if you just stay there for a second, I think just to take a couple of questions, if there's anything specific for Julia now. Yes, David.
Yes, you mentioned when we were talking about the well-established technology that it's mainly allowed only also for singular devices, but the one is. But the NCG to establish some criteria for this well-established technology. So another criteria is that it also has to be similar than the ones that the MDR maintains.
The thing is, the well-established technology just appeared on the MDR. These are the well-established technologies: sutures, dental crowns, meshes, nails. But that decision wasn't supported on anything. So they need to, on that guidance, is the argument that holds that all these are considered a well-established technology. And it's okay, the design of the medical device is quite simple, that it has been non-related to incident in the past, blah, blah, blah. No? So there is the argument on why the medical devices that are included in the positive list, they are considered well-established technology, but it doesn't mean that any device that meets the criteria is considered a well-established technology, and for that exempted for the clinical investigations. Because some manufacturers claim, no, because yeah, I'm a well-established technology because I meet the criteria, so my level of clinical evidence has to be lower. But it's like, no, you need to be in the list. Yeah. The list is, maybe, in the future they will open the list, but it's something that we, as a notified bodies, we cannot do. It's the competent authority responsibility to add more products on that list.
Okay, so from my perspective until now, I would consider, for example, a Band-Aid or something that is considered well-established technology and that the criteria also well-established.
But I listened your words in other lectures from other bodies. You are right, but it was a surprise.
Just one more from me. You mentioned about the number of medical devices that have CE marks. Through your notified body, how many applications do you get through a year, and how many in medical devices, and how many of those are from new companies bringing their first product?
Okay, so since 2021, that when we stopped receiving applications from the directive because we couldn't issue any new certificates, we have received like application from our clients now according to the MDR, and then from new companies. I don't have the number, but the ratio is maybe 20% of new companies versus 80% of all clients. But the key point here is not all submissions get through the first phase of the pre-assessment, because when we receive an application, we just go through the clinical evidence and check if it's sufficient.
How many assessments per annum?
300. Yeah. But not all get to the point of within the CE mark. Yeah.
Okay, thank you very much. So if you sit down for a moment, please. We're going to move to the open discussion, but first, so we're going to have an open discussion between Luke and Julia as regulatory experts, and David and Adriele as contract research experts. Who's David? David is David Thomas, who is going to introduce himself now with a brief presentation, and then after that presentation, then we'll get you to set up. Is that okay? You're going here. Would you like also to? Oh, is that not right, Ebane? Oh, okay.
Perfect.
Is this difficult?
Yes, I provide class. Ah, okay, perfect. It's after that presentation. Perfect. Okay, so thank you so much for having this time to sharing our knowledge and our beliefs about medtech with you, and sharing this space with you. And thank you for safe and empty. So the purpose of this small introduction is saying how a consulting company can help to run or to navigate in this regulatory roadmap that we previously mentioned, and also how to go to this audit from the notified body. So how we work on this? This is prepared for the Congress. So the introductions that we previously mentioned. So my name is David Tomé. I have been working for more than 50 years in medical devices and in vitro diagnostic products. And in the last 5 years, I have been working like consultant and entrepreneur in the CRO sector. So the purpose and even the growth in this area is coming from these new regulations, as Julia has mentioned before, that is coming from a previous catastrophe that it was related to the PIP. So those are improvements that are the purpose is improve the healthness of the patients. So what we are going to do is how we can navigate with this with a consulting company. So in our case, we propose we provide clinical research services that are very focused in design this clinical investigation or this clinical performance study. But it's not only design them, it's design them to obtain the amount and the quality of the enough clinical to overcome the inspections of the notified body, and for sure, and after that to obtain the CE mark. So is obtain sufficient clinical evidence. The other is quality and assurance that as has been mentioned before, to have a proper quality management system that is ISO 13485 compliance. Is also mandatory with a certification or without the certification. That is the common way to proceed. And also regulatory affairs with the purpose of create what is called the technical documentation. That is the technical documentation that the notified body is going to audit. And how this starts, the other services are also related to this. How this starts usually, you start with the patent of your device. So first point in your device is starting with a proper device description. And when someone is coming with a good patent, and I've made a question, okay, and what is intended for? And then usually we say for everything. This works in for several medical indications. So usually the first point is be clever and decide what is going to be your intended purpose, and decide what is going to be your device description. And from that point, we will be moving forward with the design of your device, and so the design history file, assessing your risk, preparing the requirements that is going to be needed, and after many verification and validation testing, we will end in a clinical evaluation or in a clinical investigation. What I usually see? I see that the people has a patent, and then the next step, the natural step is go into the clinical trial. And then the investigators contact me, okay, I'm going to launch my clinical trial. I say, okay, and what about your general safety and performance requirements? What about your risk management? No, I didn't perform. So it's not the moment. The clinical investigation is the end, is when we are going to validate our product. So before this, we have a lot of work to provide. And what is also very, very important to understand is regulatory is no paperwork. It's not something that when I finish my product development, I start with. I decide, okay, let's start with the paperwork to have this. Regulatory work is also like a kind of a good practice of design that is going to help me to reach the end. So it's not something that it has to be started at the end. It has to be started at the very beginning. And then if we have done this from the very beginning, we will be successful. But then if we are waiting for the end to have this, pathway and roadmap, we will be extended for a much more time than we expected. And I'm going to provide you, for example, a few examples. Let's talk about nanoparticles, because in the last 1.5 years, I have seen many patents with nanoparticles. And then when you enter in the regulatory space, you start with uncomfortable questions. Say, okay, but those nanoparticles are isolated, are coated. How is the delivery? How long time is going to be? And this is part of the product development. And if we are not considering those points, the risk of those particles, of those nanoparticles, is going to be really high. And if the risk is really high, the chance of getting the CE mark is lower. Because at the end of the day, what the notified body is going to assess is what are your benefits and what are your risks. And if those ratio is positive, with some limitations, your product will be in the market. And is the benefit against risk and the benefits against risk compared with the state of the art. And then if we put less benefit than risk compared to the alternatives, will not be there. So there are some rules also for nanoparticles that will help us to assess the risk. And we have to consider them in our product development. So my recommendation for investigators is don't wait until the end. Start working with regulatory things, because it's good practice of designs, good practice of verification, good practice of validation, good practice of risk analysis, and good practice of clinical evaluation. So this is my recommendation. And proof of concept is part of your product development. It's not part of your clinical validation. It's also your clinical validation, but in an early stage, is to know if your product is worthy, no? If we want to, or is trustworthy. So in our case, we work from startups, research centers, and also with top 10 to 20 manufacturers. In terms of clinical investigations, we are very knowledgeable also in special submissions, because the submission usually has two legs. One is the ethics committee and the other is the competent authority. But there is special submissions. And right now here we are talking about radiotherapy. And radiotherapy is one of these kind of special submissions, because it requires also a submission to the Central Nuclear Authority, the national authority in each country. But for example, in nanoparticles, there are another kind of special submissions that are related for in vitro fertilization as well, because we have to submit to the Human Reproduction National Center. In each country is different than the name, but those are very, very important. So this is part of also one of the things that is needed. In terms of clinical operations, why is important or having someone specialized in medtech? Because the clinical trials are different. And we say, why medical devices are different? Because, okay, let's think in the most common, one of the most common clinical investigations, heart valves. How can we do a randomized, double-blinded clinical trial with a heart valve in involuntary patients? It's not possible. It's completely impossible. So we need to change the rules. Good clinical practice, the standard, the common standard is prepared for pharma industry. And also it's talking about treatment. So we need to think in something specialized for medical devices that is the same, is good clinical practice. The soul is exactly the same, but is landed for what is a medical device. And what are the differences? The names are different. If we are talking about in vitro diagnostic, we are talking about clinical performance studies. If we are talking about medical devices, clinical investigation, and if not, clinical trials. But for example, one of the most amazing things, in vitro, we can do something observational pre-market. That is completely impossible to do this with a medical device. Why? Because there is no risk for the patient. If we are not doing any additional procedure or we are not doing patient management with the results. So this is something very good. Regarding timelines, with in vitro diagnostic is much more easier doing retrospective pre-market studies. That is also good. Randomization with drugs is very common. With medical devices and in vitro is unlikely that it's possible. It can be done. It can be done. I see it. I have seen sometimes, but it's not usual. Comparison arm. Medical devices sometimes is not needed. We will compare with a benchmark that we can find in literature. Population. Medical devices that are treatments usually are not big populations. We can start with a first in human in 8, 10, 12 patients, and depends on the device, we can jump to another in 40, 60, 80 maximum, but not the same number that we usually have in drugs. Placebo, okay, I think it's common sense, no, to think about this. Blinding is not easy for medical devices and IVD. Systematic adverse event is not expecting. When we are using drugs, we can expect a big list of systematic adverse events. But when we are talking about medical devices, it's something that is more limited usually, the number of the different adverse events. And one of the big differences also for medical devices are related with a procedure. And this is very, 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 very important, because usually for prescribe a drug, you don't need a high level of qualification for sure. It has to be a doctor, has to be really knowledgeable about those things. But we are talking about a transplantation or even a radiotherapy. Maybe it's not enough with being a good doctor in this area. You have to be one of the tops. And the qualification is something very, very, very important following the standards in clinical investigation. So this is it's not an extra requirement because it's included also this concept in GCP for drugs, but in this area, it gets another dimension. Okay, so what we have to look for when we are looking for a medtech CRO? Pues many things. That these people is expert in clinical operations, for sure in implementing this clinical investigation, but also in regulatory affairs, in quality, in the different areas that are focusing medical devices and or in vitro diagnostic that are different. The areas. Medical devices is very powerful in cardiovascular, for example, and if we are talking about oncology, we are talking about radiotherapy, but we are not talking about chemistry. Okay, this is a list. Very important standards, NDR, that is the regulation, the ISOs related to clinical investigations, good design for clinical investigations and performance study. And those are the points that are needed for clinical investigations. So, just mentioned, we have a broad team, and our credentials are sufficient for supporting people in terms of languages, years of experience, clinical investigation, audits, and devices put it into the market. So that's all, and let's go with the second part.
Thank you very much. So just before you sit down, so David, apologies, I was giving David the hurry up because I wanted to make sure we had enough time to have a good discussion now. But thank you so much, David, for that excellent talk. Your company doesn't actually do the testing itself, does it?
Yes. So you're related to documentation, design, and those points, but no facilities with animals or biocompatibility or those kind of things.
So you typically write
Yes, we prepare the design, the documentation, and those points.
Okay. Thank you very much. Okay, great. So are there any questions for David before we move to the discussion? Okay, then no. So thank you very much again. Okay, and Luke and Julia, very good. And Adriele. So did you want to say anything, Adriele, about the OATB before we start, or are we already?
No, I think we have comprehensively, but since Hans-Peter is here, it's important to highlight the roll-up that actually address the fact that for a sustainability of our European project, a company called OITB Pathway is actually being created to provide a bridge between science and healthcare, and is not competing with the CRO, is actually providing a guidance on where to identify the missing aspect for a product evaluation. And from that side, it's actually creating the supporting structure that a spin out or an SME might need at the early phases in order to bring their product to be then considered as a product by definition of purpose. And that's what is the result of 4 years of the European project. There were 28 partners involved. We share a large cohort of facility. And through this one, we actually mature into a structure that has competencies and knowledge in different areas, from physical, chemical to in vivo studies to the most diversified efficacy model for, and that's where the scientists come in to provide the data. And I'm delighted to hear that Julia has mentioned the fact that scientific evidence, which is peer reviewed and is also supported, can be a form of data that can be provided in support of the mode of action or the principle of function. I'll shut up then.
Okay, so I've prepared a couple of questions, but I thought just to ask first from Zor, any questions that you might like to ask this right collection of esteemed colleagues who have such expertise in this space. So any questions from the floor? Anything from the...
Alvaro was suggesting me earlier to maybe we can discuss also in the circumstance that we had at the beginning of the NoCanter project, where we had to decide whether we're going to go for a medical device or for a drug. And we were having there the iron oxide nanoparticles and the iron oxide nanoparticles with a small, really small amount of gemcitabine there. So the amount of gemcitabine that is a drug that was there in the nanoparticle was not really causing by itself any effect itself, but the combination of the both things together make that the nanoparticles were entering better into the cells, and the effect of the hyperthermia therefore was better. So at that point of the project, we had to decide whether we were going to fight a little bit more with the notifying barrier with the experts to see whether we should go with the iron oxide nanoparticle with the nanoparticle with the gemcitabine, as a medical device, or we should just focus on the simplest nanoparticle that we had, that was the nanoparticle, just the iron oxide nanoparticle, and stick to that and leave the rest. And that was a matter of a tough decision. I remember when we were in Paris discussing this, and it was difficult. So now that we have done all this road, that we still know that the iron oxide nanoparticles with gemcitabine, at least at the preclinical level, are more efficacious than the iron oxide nanoparticle. Should we get back to there and try to fight again? Not fight, but we are not fighting. We are discussing things with you to see whether there is any option to go through the medical device part also with these nanoparticles.
Would somebody like to answer this?
Yeah, the thing is, to distinguish medical device and a medicinal product is not easy. I think every week we have this kind of discussions at the notified bodies, like, oh my God, okay, what is the principal mode of action and how it is achieved? It is mechanical, it is a barrier function, it is something thermical. What is the capecitabine doing there? It has any secondary action? So I have a really illustrative example, is the orthopedic cements with gentamicin, as an antibiotic that can be the same formulation, can be treated as a medical device or as a medicinal product, depending on the purpose given by the manufacturer. If the semen is just there only to fix the prosthesis, then gentamicin is just there to avoid future infection. But if you put the semen with the antibiotic to treat an infection, is a medicinal product. So depending on the intended purpose of the manufacturer, you can go.
Yeah, so we actually, let me give you an extra layer of discussion that we had at the time, because we investigated the aspect, and the gemcitabine would have come at below the efficacy level. And we also investigated that there was no change in the actually principal activity of the API when coupled with the particle. But the question was, if the gemcitabine was the primary target and was targeting the cancer as being on the surface, that could have actually have as a mode of action the active targeting. Despite in our intention, it was just only to provide a dual function. But it is difficult to define because the hyperthermia would have actually taken place after the particle is injected. So is the injection site of a particle with the medicinal product consider a combination approach between medicinal and medical, or you have to protect the API in a way that first you go with the medical device and then you release the API. So that was the question that we had that we didn't have an answer because of the complexity of the formulation.
Yes. The purpose of the nanoparticles is to release the drug, no?
No, the purpose of the nanoparticle was to provide hyperthermia.
Oh, okay.
So the hyperthermia was as we discussed today, as Teresa Macarulla presented, the particle would actually provide a thermal treatment, and then the gemcitabine coupled to the particle would actually be then there to be already intracellularly or closely located.
But yeah, it's even more complicated because in prostate cancer, it's ablation where the heat is treatment. In the pancreas cancer, it seems to be more, it is a supportive tool to help the tumor.
I think we just limit into the pancreatic because no cancer was only for pancreatic.
Yeah, no, just say that in one time you have supportive technology, and the other time it's the treatment.
Yep.
Yes, I asked for these nanoparticles to understand what was the, but in this case, Julia, from my perspective, if the purpose of the nanoparticle is the thermal therapy, it looks like a medical device.
But you need to prove it.
But the thing is, you're putting the gemcitabine there because after the thermal treatment, it has a subsequent action.
No.
Cytotoxic action.
No. The gemcitabine was to assist the uptake in the tumor. It improves.
Oh, so in that case, we use it as an uptake mechanism. Okay.
Yes, this is pancreatic cancer. You give heat to the body, and this makes the body more sensitive for the chemical substance.
No, but in that formulation, it would have been covalently bound to actually induce the uptake
Of
and
the
then
iron, of the
of the ironocyte, and then you would have a internalized cancer killing.
So it's a functionalization in order to improve retention at the target site.
Then yeah, it looks like a medical device because which primary mode of action is physical, and then it has an ancillary medicinal substance, and as a potential notified body, we will ask for the human medicine department for that report.
For that,
but it will be CE market all the integral product by itself.
Given that the level of gemcitabine would have been below efficacy.
But you need to show no cytotoxic action to the tumor is done by the
gemcitabine.
But no cytotoxic action is not the same as a relevant.
Clinically relevant.
Clinically relevant.
With the other.
And that's what we discussed.
Yes.
If it was sub.
It's like homeopathy. What you are administering is really low. You shouldn't be doing anything.
Yes, or if it was comparable.
Or the reason why you are putting that there is not because of the cytotoxic effect that is performing, but because it's helping the nanoparticle.
But if it was within standard deviation from the cytotoxicity of the particle on their own, then you could prove that there's no add cytotoxic component because the particle on their own have their own cytotoxic profile. So
at least the main purpose of the main activity is coming from
the thermal treatment. Yes. Yeah. Okay.
It cannot be seen as a way like to reduce the amount of chemotherapy. It's the same principle as the amphotericin that we use all these liposomes to give the patient less dose because it will, the life, the half-lives will be extended. So it needs to be clear that the main mode of action is just because of the thermal and the magnetism, and gemcitabine is just there only to
vehicle the cell uptake. Yeah. Okay.
I agree.
The thing is, another example, we have like some, from severe burn that we have some hydrocolloids plasters with hyaluronic acid, and the manufacturer added some epithelial growth factor on it, and they have both the same. It's like, no, the principal mode of action is just because of the hyaluronic acid that is, they make a gel on the surface. Like, yeah, but why are you putting then the epithelial, growth factor? You cannot distinguish between who is, carrying the principal action there. So it needs to be clear in this.
Okay, right. I had the thought to ask you, panel, what question should we be asking you? What would be most useful for us to ask you? And if you don't come up with anything in the next 5 seconds, I'll ask you my question. But it struck me that maybe one of you, or No? You made the comment, Luke, that it was going to be a very unique opportunity. What would you ask you?
Look, how to prepare your technical file and your quality management system to be ready for a notified body assessment.
Okay. So when you say how to do it, do you mean something different from how do I read the rules and follow the rules?
Reading the rules and knowing the rules is the first step in that process. Obviously, you need to know what you do.
Okay.
And then you put a systematic structure in place to get there. And what I see is that the majority of the companies, as well medical devices as in vitro diagnostic devices, are not there in that systematic approach.
Okay, so another way to ask your question is, what commonly goes wrong in a submission? So maybe we can ask you, Julia, but also I think you have some insight on this, David. So,
yes, I will not say even in the submission, I will say from the very beginning. So even considering the attendees today, that they are usually in the patent stage, what are the most, is probably what I say before, is letting or lefting the regulatory and clinical part to the end and believing that the next natural stage is the clinical investigation, even when sometimes they don't need. It's not going to be the case of the nanoparticles because usually they are going to need a clinical investigation, but a clinical investigation is not fully mandatory, as Julia explained before. And what we need to do is from the very beginning, from the very beginning, start working in regulatory.
So there was that classic business manual called the 7 habits. Does anybody know it? The 7 habits of highly successful people, I think it was called. And one of them was start with the end in mind.
Yes.
So that's, is that a way of saying what you've just said?
Yes, it will be.
Okay. Julia, what do you say?
You see that 9% of certificates, we are just there because the manufacturers just failed to comply with the requirements. And obviously as well, I mean, notified bodies, we used to be like 50 or 60 notified bodies in Europe. We are just, our number has been reduced because we as a notified body, we have also failed to meet the requirements. So this is something that is shared between, manufacturers and notified bodies, all this default of not being ready by 2024. And on the manufacturer side, I will say that, yeah, the main reason to reject an application is because of the clinical evidence. Usually for class 3 implants is really well done, but for the rest of the, for example, here, the magnetic accelerator, because here we have the nanoparticles, but on the other side, that is another product different from the nanoparticles. We have the thermic, the active device.
We call it the generator.
Yeah. The generator. So that needs to be, to comply with all the tests, all the electrical compatibility, all the ISO standard related stuff. So sometimes, we get to the data and the data is just not there. No, because this has been done like 10 years ago. Like, yeah, but the standard has changed. You need to repeat the data.
So for example, with the generator, we've done volunteer tests to establish whether there is the level of peripheral heating in the body just because we're slightly electric. Would that qualify as clinical investigation?
In that sense, I mean, a clinical investigation with the nanoparticles and with the accelerator in the same clinical study will be sufficient. I mean, you don't need to perform one as separate because it has no sense without the particles.
Okay.
But sometimes another thing that usually we encounter as a non-conformity is they show us the evidence, the clinical literature, all the articles, and the medical device is not well defined. It's really focused on the patient, on the clinical stage of the disease, how all the outcomes, but the clinical, the medical device is, yeah, we use iron nanoparticles. Which ones? How were they? Were they coated? there's no information in describing the clinical device used on the clinical investigation. And I think just, but putting that information on the reference could be enough, but sometimes when you're, writing the clinical report, you just don't think you have to describe and to identify exactly the medical device you have been used.
Being specific and clear and stating what
the brand of the accelerator, the level of
yes,
of BATIOS or the amount of energy you have put on the patient. This needs to be on the clinical literature because it's not.
You mean the published clinical? So the
clinical articles that is published, you need to describe the dose, the amount of particles that you have administered to the patient.
Okay.
Because if not.
Okay. Okay.
And clinical evidence was used under the directive is not going to be sufficient, obviously, to support your application under the IVDR regulation or under the MDR regulation.
Yes.
And so you need to have much more detail under the MDR than under the directive.
Hans-Peter.
Yeah, I just have a question to the HTA regulation because as said, we should start at the end. At the end is not a regulation because then you are on the market, but not everybody who's on the market is successful, and you want to get reimbursed and you want to get money. So at the end, it's the HTA area. And now with the HTA regulation in medical affairs, we need to have some coming in Europe. We'll have some time as normal. Some common approach. How do you see yourself now, regulators, in how to work together with the HTA group in Madrid? For example, to see whether you have common outcome parameters, common clinical benefits, related to the purpose of the product and something like this.
Yes.
Have you an idea already, or do you wait till
I can speak as a notified body. That not this regulating this health technology agency regulations, I think foresees that for class 3 devices and special devices, they are also going to do like an evaluation, a centralized evaluation. And we as a notified bodies, we need to, for the first time, to submit a clinical evaluation and make it public, because until now, all our clinical evaluation remained inside the notified body. And the proof of evidence was the CE mark. So no more evidence was in the market, just the CE mark. So, researchers couldn't really get to the point of why is this on the market? So now with UDAMED database and with this kind of regulation, I think transparency will be enhanced and we will have more access to data.
Yes.
Do you think also about some kind of communication in advance so that what you are regulating should to then reimbursement?
The point here, because this is starting to be a trending topic, and in the last year it's very, very important. The point is how do you assess the clinical data for CE marking and how you assess the data for usability, clinical utility. It's a bit different. Because in clinical utility, you are introducing one factor that the notified body is not assessing, that is the economic factor. And
not for HTA regulation, it's just the medical part. It's just the clinical.
Okay, if it's just the clinical part, but for reimbursement, as far as I know, the economic part is also relevant.
This is the Spanish topic and my German topic.
No, in fact, in Spanish, there is no reimbursement. There is no, it's working a different way. It is more from Germany and other countries. It's not economic part important. Okay, so I was wrong, sorry.
I'm sorry to say that we are now past the advertised closing time. I proposed, if it's okay with everybody in the room, that we continue until 25 past. It would be 10 minutes over.
What time is?
It's now almost 20 past. So another 5 or so minutes. Is that okay with everyone? Okay, then we'll continue. Sorry.
So one point. So for reimbursement in Germany, how much is cost the treatment is not relevant? Okay.
So right now, the MDR, IVDR, that's European regulation, and the reimbursement is national authority. So that's obviously a significant difference.
Can I pose a question to this, mostly to Julia and Adriana, I think. Adriana, I believe that in the OITB pathway, you have organizations that are undertaking tests that are ISO compliant. They're following to the letter the things like biocompatibility, cytotoxicity, intracutaneous reactivity, and all those things around the nanoparticles, but they do not have certification as being ISO compliant. So they're doing ISO compliant tests, but they're not certified. Is that correct?
Yeah, yes. And there's an additional component. Under the OITB, we apply the ISO standard, the 10993, whatever section is requested. I think Julia referred to 1722 is also viable, the biological evaluation plan. The aspect that we are not complying is because we are testing the nano component on the biological or the biocompatibility, which is not specifying the ISO, which is one of the parameters that is not actually spelled out. And that's what we are currently doing. So we have added an extra level of technical assessment, which is based on the scientific base and on the resolution and the sensitivity of the assay that we're using.
So what does the panel think about this? Is it going a little bit off-piste for for following ISO regulations, partly through not having the laboratory being certified, but also partly through making the value judgment that what's written down does not
include the specific assessment for the nano property.
The nanomaterials, so that we as a group have worked extremely hard to come up with an agreed way of doing the testing, which we think is logical and defendable, but nevertheless, it's not what's on the paper.
So the MDR requires that every time you do a test to check the safety on humans, you must follow the good laboratory practice. So, and the test must be conducted through a laboratory that is has a certification of it, or ISO 17021. But we are persons, and as a notified body, if we receive a test that hasn't been performed against that standard, maybe we will with a justification, a proper justification, saying, okay, I couldn't find any laboratory that is accredited or is certified against this good laboratory practice. And instead of just checking the report, we are gonna ask for maybe the protocol or the ISO guidance of the laboratory. Maybe we will ask for more information instead of just, checking the report. If it's not ISO, if it's not certified, if the laboratory is not certified, maybe we will ask for more information.
To come to that side, we actually self-impose ourselves an inter-laboratory study between different partners inside the project to repeat the same protocol, which is being derived from the ISO, but to test the nano properties. And we actually provide the variability and the confidence variance within the partners on testing the same property. So in that case, we're actually testing ourselves against the standard with this clearly defined protocol that is being circulated. Could that be a sufficient evidence?
I mean, I can't say,
without seeing in principle, without seeing, yeah.
But obviously a justification and a rationale why you can't provide a test performed under the certified conditions.
For instance, the very
it's not a no.
The very controversial issue for particle is sterility. You actually have an issue with testing sterility that if you don't have proper control, you actually induce interference into your assay, especially the LAL assay. And that was one of the issues that we had. We had to resolve the interference aspect that was induced by the particle of magnetic nature, for instance, against readouts. And that's where we came with a solution. I think we have a very strong scientific evidence by proving that there's plenty of literature. And we are actually providing, and we're creating a piece of data that is missing in literature, which are part of an interlaboratory study.
But the response I'm hearing from you, Julia, is that the notified body will not just throw it away.
No, we'll consider on the premises that you provide a suitable justification, which is based on the factual and on the lack of evidence or the lack of an organization that can test with the proper certification. So if you happen to be the most expert in that particular testing and you develop instrumentation, then you are the fit for purpose.
Because how many laboratories are in there that can perform the test on nanoparticles? I don't think, I don't know, but I'm less than 10.
But it's also important as that there is a good protocol and you are following the protocol and the protocol is following
quality
the ISOs.
criteria. Yeah. So that's what we did, and we developed that with experience that we have historically by working in the field.
Are there any other questions from the hall? In which case, I have one last question which I want to squeeze in, which Giammaria may be able to speak to. All these hyperthermia therapy cancer indications that Giammaria showed us with hyperthermia plus radiotherapy, hyperthermia plus chemotherapy, chemotherapy 1, chemotherapy 2, chemotherapy 3, indication 1, pancreas, cervical. Are all of those separate CE marking applications? How does that work?
So with the same CE mark application, you need to write down the claims you are doing for pancreatic cancer stage 2, for mammary cancer stage 5. And then we need to we go to the clinical evidence evaluation and check you have provided evidence for all your claims, for all your intended
As
purpose.
more ambitious you are, more things you have to validate.
So has this been done, Giammaria, for, say, MEHT?
I didn't understand your response just now. What is your opinion?
Okay, we need to find evidence, clinical evidence for all the intended purposes.
For every tumor, yeah?
For every claim.
For every
yeah.
So that's what when it was asked for the MEHT. Did you go through
In fact, this was what I said in my, because when I start working with the patents, you say always, what is this intended for? You say, for almost everything. On the cancer, everything that you say, you have to validate it.
No, I think that the best way is step-by-step identification of the target, define the quantity, the exposition, step by step, because if we adopt the same treatment for all situations, all kind of tumor, all kind of diseases, is impossible to define. This was one of the limitations of hyperthermia, because as I told before in my presentation, hyperthermia had a peak and increase, and then this disappeared in 89, and then this disappeared because the application was without a clear criteria. And so it should be better to have 1, 2, or 3 clinical situation of pathology or stage of tumor in which you can use the hyperthermia and you have some major evidence of that, of the successful.
Thank you. So I think that's the clinical perspective on that. Any comment from the panel on that?
Yes, no, it's true. Your approach is the right one.
I mean, you can go for the first, pivotal clinical investigation with one intended purpose and then apply for a modification of the CE mark. And usually, the number of patients will be reduced because some, for example, side effects will be already checked on the pivotal, and then usually then the N will be reduced as far as you are adding.
And one tiny last question from me. So is there a database somewhere that spells out what each company's product's CE statement is?
It will be when Eudamed is active.
Okay, Eudamed now is a public database when you can check, you can look for a device. And I think you can even search for nano or nanomaterial, no? Devices with nanomaterial. The thing is, it's not mandatory, so it's voluntary. Manufacturers can just update the data when it will be mandatory once all the modules are finished.
But for example, with this MEHT instrument that say the Oncotherm, or you could look up that particular medical device and see what it's got a CE mark for.
Not at the moment.
Pardon?
Not at the moment.
No, not at the moment. Okay.
You can do in FDA. FDA is much more transparent, and the purpose is that the Europe will be, but we are in the transition.
All right. Okay. Oh.
Yeah. How the science have progression as successful in oncology, for example. Okay. In the last 30 years, we have seen that we have some new information, for example, in one type of cancer, lymphomas. And we treat lymphomas with new ideas. The same in breast cancer, and you treat the new cases with new idea, new drug, new oil, and so on. And generally, we try in oncology, in medical oncology, to apply the criteria that was successful in the other field. But this is not true that will be efficient in another field. Yeah, but it's very stimulating what we have seen and what was successful. But we have to identify where, when, and why. Always.
Where, when, and why, a great place to stop. Thank you very, very much to the panel. Thank you very, very much to Ibane for bringing this all together, and to, where's Clara? Clara, thank you, thank you, thank you, thank you. We had some imaginary flowers. They would be winging their way to you. Okay, so I think that's, thank you very much, everyone.
And thank you very much for everybody connecting online, for posting the question, and for the attendance throughout the day. I think it's been a very fruitful and successful conversation, discussion. The conversation doesn't close here. You have put names to faces, faces to names. So that's the first start, and we're going to be here for a few hours. But at the same time, we are now posted on Twitter, on social media, thanks to Marta, that has been kindly taking pictures of all of us all day. I think the key message is there's quite a lot of work, but there's a positive intention to drive forward. The hyperthermia plus nano component is a very attractive field, also a challenging one from the regulator perspective, but there are ways that can be brought for discussion with the notified body and the regulatory agencies. So I think it's actually a very good point where to start discussing from the example of what Spain has provided us and where we are currently, in the way to put everything through the pipeline to actually treat patients. And we shouldn't forget about patients and their well-being. In terms of the aspect of coming to have a larger cohort of modalities to treat cancer with hyperthermia. And this is, to me, is the key point. And so multifocal nanocancer were a learning curve for us. We have a lot of imaginary tattoos from the scar that we had, but it was a fantastic journey. So I wish everybody can pursue that and engage with and the team and regulatory in terms of bringing more product into the market. Ibane, last word?
Just to give thank yous to all of you. It was really nice to have you here, and this is it. No, nothing else to say, really.
Thank you. Thank you very much, everybody.